Session. So you want, there it is. Hello and welcome. So glad everyone is here. Happy SIBO Awareness Day. This is a huge, huge deal. It's an honor for me to be here hosting today. My name is Siobhan Sarna, and I wrote a book called Healing SIBO, and I have SIBOSOS.com. And for the past 10 years, I have been working diligently with SIBO experts to get the word out so we can all not just have awareness, but we can all take action to help support our microbiomes and our SIBO and resolve it ASAP. My honor to have all of you here. Now, the SIBO Awareness Day 2026 is the second annual one, and we want to thank the organizers, SIBOawareness.org, and also Gut Microbiome Foundation for their incredible work of expanding the awareness, the education, the resources, the possibilities, and the hope. And Sadie is here. She says hello. She is my co-host, and the hope for resolving this really annoying condition that obviously has a lot of downstream effects, but also with the diligent work of many people, many of which you're going to be meeting today, we're going to hopefully be seeing a cure ASAP. So just lots of good vibes to everyone who's working on it. We're going to have a variety of speakers today. We're going to do some giveaways. Of course, one of the value systems of all parties involved is be nice or be gone. It is a public forum, so we do take that very, very seriously. And I think that if you don't have any questions right now, we are going to get started. If you have any logistical questions, do pop into the chat to the host and panelists. They'll do your best. What I find is leaving Zoom and coming back usually resolves a lot of issues if you have any. I don't think we have any like Zoom insider tech info, but that is a quick fix often. If you have any questions, do put them in the Q&A box, and we will go ahead and get started. So my very first guest is the esteemed Dr. Allison Siebecker. And I do have to say, she's one of my favorite people on the planet. Hi, Dr. Siebecker.
Hi. Good morning.
So a little
Thanks, Siobhan.
Hi there, Dr. Siebecker. Dr. Siebecker and I have been working together for 10 years, believe it or not, and she was doing this way before that as a true SIBO specialist. She's an award winner from her peers with already a Lifetime Achievement Award, what, in your 20s? And very, very early in her career, she already was really making waves and making sure that people around the globe know about SIBO, both patients and practitioners. Her website, siboinfo.com, has helped millions of people learn more about the condition. It has recently gone through an overhaul, a glow up, and so if you haven't been there lately, be sure to stop by. She and I at SIBO SOS, siboinfo.com, we co-produce a variety of events, and be sure to sign up for our newsletters, etc., so you can find out more. A lot of which are free. A lot of them have Q&As attached to them, so people can really get a lot of personalized attention. It's amazing what can be accomplished on the internet. So, Dr. Siebecker, I know that we have a lot of questions for you today. We're going to be doing an overview about what exactly is SIBO, small intestine bacterial overgrowth.
Okay. Well, the definition has changed over the last several years, believe it or not. And we now kind of have three types of SIBO we always had these types of SIBO, but with new names. So first of all, the basic definition is, it is what it sounds like. There are bacteria that are overgrown in the small intestine. There's a small intestine and a large intestine. We used to think that it was just too many, like too many in the wrong place, because the small intestine is where we do our digestion and absorption of food. And if there's too many bacteria, they interfere with that process, which is what happens in SIBO, and it causes a lot of problems. But we have expanded the definition because we have these three types of SIBO that are based on the gases that the overgrown microbes make: hydrogen, methane, and hydrogen sulfide. And the methane and hydrogen sulfide type, it turns out they can overgrow in the large intestine as well. And so they had to change the names. So now what we used to call methane SIBO is called intestinal methanogen overgrowth, or EMO for short. And what we used to call hydrogen sulfide SIBO is now intestinal sulfide overproduction. So, yeah, so where the definition has changed is that now we know the same things disease processes we were thinking of can be large and small intestine for two of the types of SIBO. The other thing is that Dr. Pimentel and his wonderful team, of which Dr. Razai will be here speaking later, have done a lot of work to figure out exactly which bacteria or microbes are overgrown in these different types of SIBO. And so we now have that information, which is really helpful. We didn't have that information when I first started in SIBO, right? So now that we know, we can target our treatments better, and it clarifies what's going on. So for the hydrogen type of SIBO, it's been identified that it's E. coli, and this is the non-pathogenic type of E. coli, more of the commensal type of E. coli, Klebsiella pneumonia, and a little bit of aerogenes. For the methane type, it's M. smithii, which is not actually a bacteria. Another reason for the name change. It's a methanogen or an archaea. And then for the hydrogen sulfide type, it's really interesting. They were able to find that it's different bacteria in the small versus large intestine for the hydrogen sulfide type. So for the small intestine, it's Proteus mirabilis mostly. And for the large intestine, it's Desulfovibrio piger and Fusobacterium varium. And I know that all sounds like a bunch of gobbledygook, but just thought I'd share it because I think it's amazing information, you know?
It is an amazing set of details that was not available until they have been mapping that small intestine over there at the MAST program in Cedar Sinai. So it's really, really impressive. And just if you know what's causing it, they can work on getting the lock and key solution, which I know they're actively working on every single waking day and minute. I know.
Yeah, and it was a big surprise, I think. Dr. Pimentel has always said it was a big surprise to him to figure out that it was just like one or two bacteria involved in this condition. That was surprising.
And he also talks about on the many blessed times we've had a chance to interview him together about how it's like a neighborhood and a gang, and that those bad players are acting out and ruining the neighborhood for everybody else. And when they do get under control, hauled off, whatever, removed, shall we say, then the garden, the neighborhood can come back into homeostasis,
Yeah,
which is so reassuring.
yeah, yeah,
That microbiome, a lot of us are very focused on it, and it is a microbiome condition. And that's what I think, he told us about. Someone came up to him and said at a conference, "You've brought the microbiome back to gastroenterology." And I just thought that was a brilliant statement, because I know from going to certain gastros over the years, there was no connection of the microbiome to IBS, SIBO, and all of that. So, what are the symptoms, Dr. Seebecker?
yeah, right. Of course, this is the thing that everybody focuses on and is so important. The hallmark symptom, the sort of the keynote number one symptom is abdominal bloating, or another word for that is distension. Basically, when the abdomen swells out, and this always happens in terms of SIBO pretty much after eating. And that's one thing we can say is that the symptoms of SIBO come after eating. So it's related to food and diet, which is one of the most awful parts of the symptoms, because then, as I'll explain with the other symptoms, we know that these symptoms are related to eating, and then we get like afraid of eating, afraid of food, and we start restricting our diet and things like that. So that's the number one symptom. Then we have bowel movement changes, so constipation or diarrhea, or a mixture of the two. It could be that they alternate, some days are constipation, some diarrhea, or it could be an odd just mixture, because bowel movements normality are defined by both their texture and the frequency. So you could have, like, say, the texture of diarrhea, but very, very infrequent of constipation. So this odd sort of mix that could also happen as well. And then another terrible symptom is abdominal pain, or could just be discomfort. And it could be severe pain, it could be mild discomfort. That's another thing that occurs, very unfortunately. Then there could be excessive belching or flatulence. A lot of people have a lot of flatulence with this condition. Um, there could be nausea. And another one that surprises a lot of people is acid reflux.
Hmm.
So that's a common symptom with SIBO is acid reflux. A lot of people walk around with that as really their main symptom, and they are not thinking about SIBO actually. There also can be some sort of mental or emotional impacts. Anxiety is really common, actually. There can be depression as well, but anxiety is more common in SIBO, and that's been shown in studies, and we see it clinically. So that's a good thing to think about that, that if you are having anxiety or your patients are having anxiety, that it could be from SIBO and that will go away when the SIBO is treated, and that it's not necessarily a personality thing. Like some people think that they're creating it themselves or something like that. But there's physiologic processes that can create this anxiety, can wake people even in the night. And then there can be brain fog. And of course, last of all, fatigue. I mean, from everything I just mentioned, it's rather tiring. So
Right.
a lot of fatigue.
The microbiome impacts how we think, and how we think, how our mind, is impacts the microbiome. So to hear you say that it could cause anxiety and depression, how many people are thinking, oh my gosh, I'm just having a lot of mental health issues, and they're going in a
Yeah.
different direction. So I'm really glad we're having this conversation.
Yeah, and people might just think, oh, I have a stressful life, and most of us do.
Yeah.
And that can cause all sorts of mood changes, and maybe it is that, but maybe it is related to this microbiome disorder of SIBO. So,
So those are some of the symptoms. And when should you suspect SIBO?
oh yeah, so this is something that I just wanted to share. These are ways to think about when it might be SIBO, because the thing is, those symptoms that I described, the core symptoms, pain or discomfort, bloating, and constipation or diarrhea, those are the symptoms of IBS. And these symptoms relate to many other diseases. There's so many other conditions that can have these symptoms. So I thought I'd just share some things to think about when it really might steer you more towards SIBO. So obviously those core symptoms, and particularly bloating, and as I was mentioned, acid reflux. I think it's appropriate when we have the main symptoms of IBS, the main symptoms of SIBO, to think about SIBO in one of the top things we're thinking about because it's very common. But another thing is something I was just alluding to, which is when there are a lot of food sensitivities. If you or your patient has a lot of food sensitivities, and or they've already begun restricting your diet. If you started doing that, I'll try gluten-free. I'll try all these. I'll try dairy-free. All these different things. And then if you know about FODMAPs, I'll try FODMAPs. And within that, having a lot of food sensitivities, if you can notice, is it eating healthier that actually makes you feel worse? That's something when you want to think about SIBO. Like what I mean is you're eating a higher fiber diet, you're eating more salads, you're eating more raw vegetables. Maybe you start doing green smoothies, like raw green vegetable smoothies. That's a big thing. You switch from white rice to brown rice, and now you're feeling worse, right? Or you're eating more whole grains. And then some classic trigger foods for SIBO are onions and garlic, which of course are ubiquitous in all cuisines around the world,
So true.
uh, and apples and stone fruits like peaches, nectarines, plums, things like that. So any of these things you've noticed are more what is bothering you, I would think of SIBO. Now, another one would be bringing it to sort of some of the causes, which we haven't talked about, but we will.
Yeah.
Um, when your symptoms started after having food poisoning, because that's the most common cause of SIBO, and that is classic, right? And now sometimes it might not be right away, it might be like a month or so later. But if that's really the thing, the trigger that you can link it to, that is when you certainly want to be thinking about SIBO. And also just know that food poisoning has other names like traveler's diarrhea and stomach flu. So that's one. Another is when the symptoms develop after taking a proton pump inhibitor. This is a risk factor for SIBO. And a lot of people can link this to their symptoms to the proton pump inhibitors or opiate narcotic painkillers. So, clearly, given for some other reason, maybe a surgery or, some pain, back pain or something you're experiencing, and now your GI symptoms began. So think of those things. Another one is if the symptoms started after surgery, after abdominal surgery. That's another one to think about. Um, and sort of a reverse thing is, let's say you were giving antibiotics for some reason, like a sinus infection or a dental procedure or, urinary tract, whatever. And now your GI symptoms got better. That is another reason to think about SIBO. It's not like that would happen for everybody, but there's certainly a subset of people where they're just, they're given the right antibiotic that's going to work for their type of SIBO. For some other reason, all their symptoms go away for like 2 weeks. So, and then I just have just a few more that are about supplements. When, if you're taking probiotics, or your patients are taking probiotics that have a good amount of prebiotics in them, so that's things like FOS, GOS, MOS, inulin, arabinogalactan, larch, chicory, Jerusalem artichoke. There's probably more. Those are the main ones I could think of.
Yeah.
Uh, if that probiotic supplement with a good amount of those prebiotics, it worsens your GI symptoms. Or if you just took a prebiotic supplement, you just, got FOS and were taking it and it made your symptoms worse. And similarly, you take a fiber supplement. Um, and a keynote here is if it makes your constipation worse, or your patient's constipation worse. We think of fiber as a treatment for constipation, but in somebody who has their constipation from SIBO, and in this case it's EMO, the methanogen overgrowth, that's linked with constipation, the fiber can actually just feed. That's what all these carbohydrates and things are doing. They're feeding the bacteria, the methanogens, they're making gases, and those gases are creating the symptoms. And then the one last one I have is, what if you were given a gut healing supplement? You have these symptoms, or
Yeah.
you decide to take it yourself. It's like, I better do some gut healing. It's a great thing to do if that makes your symptoms worse, because again, that has mucopolysaccharide carbohydrates that can feed these bacteria. Now, all of these supplements are amazing. But maybe just when you're in the height of your SIBO, it's not the best match. We just need to clear some of that SIBO, and then you'll be able to use these supplements. But these are just ways to suspect this could be actually SIBO.
And I think what's also important to note is that often when the SIBO is resolved, those food sensitivities go away. Your fructose, sensitivity goes away. So I just want to remind everybody that like the main, yes, the terrain is important, absolutely. And on the other side of reduction of the overgrowth, that all can, like that garden we were, the neighborhood, that can all come back into harmony. We love that part. And it happens typically automatically from having the bad players removed.
Yeah, absolutely. In fact, the gut, there are studies that show that for those people who get leaky gut from SIBO, which studies show about half of people with
Mm,
SIBO will develop leaky gut from it. I'm amazed it's not everybody, but
yeah,
not everybody that happens to. But after you just eliminate the SIBO and then they retest like a month later, there's no more leaky gut. So it's good
beautiful.
to know, the body can heal on its own, homeostasis can return when we remove the offending situation, right? And we
Right.
can think of that like if we get a cut, our body can heal a wound, right? So same thing. If we remove what is actively creating damage inside the intestine, our body can just heal that wound up.
Great, great analogy. Okay, so let's talk about underlying causes. What causes SIBO?
There's a huge list of things, a really large list. So I'll just mention some.
Okay.
I already mentioned food poisoning, and this is again, of course, the work of the fabulous Dr. Pimentel and team, Dr. Razai included, who will be here speaking. They spent years mapping out the exact like pathophysiology and mechanism to prove and show how food poisoning can lead to SIBO. So that is our most common underlying cause of SIBO, or cause of SIBO is food poisoning. But there are a lot of other causes as well. So some are medications. I mentioned a few when I was going over when to suspect. So, like opiate narcotic painkillers can lead to SIBO. Proton pump inhibitors are a risk factor. Usually, they're in combination with some other factors that could lead to SIBO. And actually, I talked about antibiotics making SIBO better, but antibiotics can also be a risk factor to create SIBO, believe it or not. So those are some medications to think about. And I have to say, I've had so many patients that said they link their GI symptoms beginning actually after taking antibiotic. So it's sort of the opposite of what I was saying before. But then we have a whole list of diseases that can lead to SIBO. So there are a lot of common ones like diabetes, actually, hypothyroidism, which could be autoimmune, like Hashimoto's, or it could just be non-autoimmune hypothyroid. So common, right? I mean, so common. Ehlers-Danlos syndrome, not the most common disease for people to know about, but it actually is a common disease. It's gaining more and more awareness. Very common to have SIBO with Ehlers-Danlos. Parasitic infection. So many people have parasites and don't know it. Even in our country, we think of it as, maybe traveling to a third world country and getting parasites, but parasites are common. Endometriosis is a disease that can cause SIBO very commonly. One that Siobhan and I see and deal with all the time is mold illness. So, mold intrusion into buildings, work buildings, home buildings, cars is extremely widespread, really like almost an epidemic. And many people's immune system can't tolerate that. Not all mold is black mold that we think of as being super serious. Some of it is, but there's all kinds of molds, and people can develop illness when exposed to these molds, and that can lead to SIBO. And the reason that Siobhan and I are always dealing with this is because we do tend to deal with a lot of people who have more difficult to treat SIBO,
Mhm.
SIBO that is not responding the way we would think it should to our treatment, or that is relapsing too much. And very often it can be mold illness that is causing that. It creates difficult to treat SIBO. And then just a few other diseases to keep in mind would be things like inflammatory bowel disease, that's Crohn's and ulcerative colitis, traumatic brain injury, which again, not a lot of people think about, but it is an epidemic, believe it or not, Lyme disease and the co-infections that go with that, and Parkinson's disease. So many things, so many diseases can lead to SIBO. And then I want to just mention one other thing that isn't diseases per se, and that would be more of structural, anatomic situations. And probably one of the most common there are adhesions. And these are like scar tissue, scar bands that can form inside the abdomen. And they can form in such a way where they press on the small intestine and lead to an overgrowth situation. But adhesions are formed from things like infection, so maybe like appendicitis or inflammation. Appendicitis has that too, or trauma. If the appendix bursts, it has that. So that's a good example for all of them. But other things that lead to adhesions are surgery. That's why I mentioned if GI symptoms develop after abdominal surgery, or any kind of injury like a car accident or a sporting accident, a fall off a bike, things like that. Also radiation, hemorrhage, and endometriosis. So there, I've said enough things in a big long line
No,
and
it's
list,
good.
but it
It's
just
so
it gives
good.
you a sense of it, right?
Right. And someone's commented in the Q&A box GLP-1, which is definitely appropriate to be mentioning
Oh,
too.
thank you so much.
Yeah.
Yeah, we have two studies that just came out last May at DDW, which is Digestive Disease Week, the biggest gastroenterology conference in the world. And it happens every spring. And of course, thank you for whomever said that. We have long suspected that since they came out, but we got the proof. So two studies showed that GLP-1s can lead to SIBO.
So just a big bow on this, the migrating motor complex.
I haven't
Like
even mentioned it.
I haven't even mentioned it. But so for those of you who are like, wow, all of these things, what's the one thing in common
Yeah.
with all of those things, Dr. Seebecker?
Okay, so the underlying true physiologic cause within the body that causes most people SIBO is a deficiency of the migrating motor complex, or we call it the MMC for short. And this is just a form of motility or a form of peristalsis or movement that occurs within the small intestine only. This is not in the large intestine, just the small intestine. And its purpose is to clear bacteria is normally there in the small intestine anyway, to clear it down and out, move it down into the large intestine, and then it gets excreted. So it is really the body's number one protection against getting SIBO. There are others, but it is there for a main purpose of making sure we don't accumulate this overgrowth of bacteria in the small intestine. And most of the conditions and medicines that I mentioned slow the migrating motor complex. Some of them damage nerves that are needed to perform that function. That's what food poisoning does, actually. Now, on the other side of the more anatomical causes like adhesions, that's we're talking there like about a blockage or like a partial obstruction. So that's like a physical, like a log jam in a river. And in a way, you can even think of the migrating motor complex sort of like that, in that if things slow down, your flowing river becomes, like a swamp, basically.
And so when people talk about motility disorders, I remember I heard that word for the first time many years ago, and I went to my acupuncturist. I was like, "Oh, I have a motility disorder." Finally, like that was the answer. And she was like nonplussed. She was like, "Okay, well, what do we do about it?" Like she was not like, "Oh, you found the golden ticket, Siobhan." Even when it was like, "Okay, then after that, I found out about SIBO." She was still like, "Okay, but what do we do about it?" So
Well, because this is the biggest issue is that if you have something that is damaging your ability to perform the migrating motor complex, how do you fix that?
right.
So it unfortunately becomes not so simple. If you can cure the disease that is affecting it, great. But some of these diseases, unfortunately, we have no known cure for at this time. There are always scientists and doctors working on figuring that out. But so sometimes it becomes that's why we can sort of understand chronic SIBO, right? And it can be a little bit more complicated. It's not the simplest answer.
And there's also ways to manage it. So let's say
Oh
you do
yeah.
have an underlying cause that cannot be like a quick fix. There's, as I always say, 100% feeling
Oh,
better from a managed chronic condition like SIBO than untreated.
well, this is a really good point because we can mention this in a minute here, but we typically see 80 to 90% success or improvement when treating SIBO. So, like 90% symptomatic improvement is the goal and the norm. And that's incredible. And when you look at the statistics for the various treatments of SIBO, which have all been studied numerous times, we get into the 90% success rate, which is astonishing for any disease. So that's the super good news. Super
Yeah.
good news. There may be a complicated underlying cause that isn't the easiest, simplest thing to snap your finger and make go away, but that doesn't mean you can't live at 90% symptomatic improvement, right?
Right. Exactly. So, how do you know if you have it? How do you diagnose it? And then we'll cover the three main treatments. So go for it. How do you know if you have it? What's the best way to diagnose it?
Well, it's super important that we do a test. We have two kinds of tests we can do that diagnose it, a breath test and a blood test. And we do need, officially, according to the definition, to have a test um, to make the diagnosis. And that's because of what I talked about before. The symptoms can apply, those basic symptoms can apply to so many other conditions. So you can't just use symptoms alone. You can suspect, but then you need the test to figure it out. So let me mention the breath test first. That's the main test we tend to use is a breath test. And what we're doing there is just checking for those gases I mentioned in the beginning, the hydrogen, methane, and hydrogen sulfide. And, we just have sort of criteria that we use when we see there's, a certain amount or greater, then we know it's SIBO of those gases. Those gases get made by the organisms. They diffuse across the lining of the intestine into the blood. The blood brings them to the lungs, and then we expire them out. That's how we can do a test. It's an indirect test for these microbes. That their presence is indicated by the amounts of these gases. And in particular, hydrogen and methane are only made by these organisms, not by humans. So if we see these gases there, we know. And for hydrogen sulfide, we make that gas too. Humans do, but it's the amount that indicates it. So the breath test is really easy to do. The hardest part is there's a prep diet the day before that nobody really likes because you have to sort of narrow down your foods for a day. But the test is very simple to perform, and the diet isn't terrible. It's just a bit of a nuisance. And then it's easy to perform. Most people do it at home. You could do it in a doctor's office or at a clinic or at a hospital, but a lot of people will just order in kits and do it at home, and you do it in the morning, after you haven't eaten overnight. And it takes 2 or 3 hours. And it's very simple. You just drink a little substrate first, sugar solution, and then you breathe into these collection tubes. So that's how we do the main test, right? So that's super important to do that. And then the other test is a blood test, and again, developed by Dr. Pimentel and team based on their work of figuring out about food poisoning. And this is a test that actually tests if you have SIBO from food poisoning, but it's also used just basically as a screening test for IBS or SIBO. So this is a wonderful test. Can be like a great first test for a lot of people. And if there are any primary care docs listening, it's a great test for primary care doctors to just run as a screening test to just get a quick sense. Are these symptoms that this patient has, is this SIBO? Is this IBS? So if this test is positive, it diagnoses IBS, it diagnoses SIBO, and in this case, post-infectious IBS, which is just IBS that is formed after food poisoning. So, and then the other thing that's great about this test is you know that what is physiologically going on is there's deficient migrating motor complex. It's by the nature of this very test and the whole mechanism it's based on, it will diagnose indirectly deficient migrating motor complex. So then that's helpful because there are medicines that treat that. We didn't talk about that earlier. Prokinetics. So these are either natural or prescription agents that stimulate the migrating motor complex. And if you have a positive, like this is IBS smart test, basically, then you'll know prokinetics are absolutely needed and indicated. And that's helpful. And also it helps for patients to be compliant. They have a test showing they need that as a medicine. So a very helpful test.
And then what about the aspirate?
Oh, yeah. So, of course, you can do a culture test, or even, I guess we could call it like a DNA test. But this is where you're getting an endoscopy, or if you're performing an endoscopy, you can take a sample and culture it out and see if there's overgrowth that way. Problem is, there are problems with this test. It's easily contaminated by bacteria from, the mouth, the esophagus, or stomach. Um, Anaerobic bacteria may not grow when cultured, which is why it's probably better to do DNA. Um, and there's just some other things. There are bacteria that, you can grab a sample from basically the lumen, or like the middle of the tube, but sometimes you need to see the bacteria that might be under a mucus layer. So again, Dr. Pimentel and Dr. Rosine team have developed a new way of doing this test, which is much more appropriate to figure out for use for SIBO. I don't know how well it's been adopted. I don't know how many centers follow the new procedure. It has been
Mhm.
validated. So we just have to remember that, this has always been used as the gold standard. But we always used to say it's not very golden. And so once Dr. Pimentel figured out how to improve this test, things got a lot better in terms of our studies. But this is not, that's not a test that we're going to be doing on a regular basis. It's more
Right,
like if you're going in for some other reason and you're getting an endoscopy, you can ask for this.
right. If you have a positive breath test, would the blood test provide new information that would help with treatment?
Um, I think so, because it lets you know that the underlying cause, or we could say the cause is food poisoning. And then that lets you know that if you're traveling anywhere, like basically it lets you know to be extra cautious and preventative for further food poisoning. Because once you've had food poisoning, it's more likely to get food poisoning again. There are studies showing that. And you can sort of worsen your own SIBO situation if you get food poisoning again. So you want to be extra careful to prevent food poisoning. So this might change some of your habits, like
Right.
your eating out habits. And there are things like you can take some of our treatments for SIBO. You can take them at reduced doses if you're traveling with meals, like if you're traveling to a third world country or a food prone area. Although food poisoning can happen anywhere. So I do
Right.
think it affects treatment, and also you know that. As I said, you have deficient migrating motor complex that can change treatment because believe it or not, although we tend to use prokinetics all the time in SIBO, there are doctors that don't want to use them. They may not be fully educated on them, and they may they may only think that there are unsafe prokinetics because there are some unsafe prokinetics, and they may not understand there are safe prokinetics, and so they may
Right.
have something against that. This will, really show that they need to use a prokinetic, hopefully one of the safe ones, that sort of thing. So I do think it affects treatment.
And so if the IBS smart test comes back negative, it doesn't mean that you don't have SIBO. It's just helping to understand the underlying cause and understand your migrating motor complex.
That's
Like,
super important. If you
right.
start with, thank you, Siobhan. If you start with that test and it's negative, it just means you don't have SIBO from food poisoning. But then I went over a whole bunch of other
Yeah.
causes, medications,
Yeah.
diseases, adhesions. You still need the breath test to figure out if you have SIBO from those causes. But very often that test is positive. And so,
Right.
but then I still recommend using the breath test to know which gases are positive because that affects treatment and how high. Because we base our treatments, at least for two of our methods of treatment, on the gas type.
And even if you had food poisoning a really long time ago, it could still be impacting you today. So we
Yeah.
just wanted to cover that. Okay, so we have a little bit of time left, which is great because we want to pull up that algorithm and the overview of how it's treated.
Oh, yeah. Okay. So I got this ready to go. Let me share my screen.
And you can order the IBS Smart Test directly from Gemelli Labs. So there was a question about that. I just wanted to take that on. You don't,
Yeah, and breath test too.
yeah.
If you go to, Siobhan mentioned earlier, I have a free educational website called SIBO Info, and let me just get this big screen. I have a testing page that's just a resource for everybody that shows all the different labs and all the different tests and shows you how you can order these tests. Patients can order it directly, or doctors, shows you everything you need to know about both of these tests are, on that page. So siboinfo.com testing. Okay.
So, yeah,
Yeah,
this
yeah.
is gold right here. This is what Dr.
Yeah.
Seebecker and I call gold. Like,
So I just
everybody
wanted
pay
to
attention to this.
share this as an overview because what this is this is a variation of Dr. Pimentel's original SIBO treatment algorithm that he first published, I think, in 2006. So a long time ago now. That's 20 years, isn't that? That's 20 years. Amazing. But it's slightly varied by myself and my colleague, Dr. Stephen Sandberg Lewis. So let me just take you through it. It'll give you a map and a good sense of, because you're going to listen to other talks today that are going to talk about parts of this. So first, we suspect SIBO, which we've gone over based on the symptoms and those key indicators that I talked about. And then what a lot of doctors do, and patients do, is but without even knowing what's wrong yet, they don't know it's SIBO or not, they just try some things. Alter their diet, as I mentioned, try various supplements, enzymes, digestive tonics, things like that, probiotics, and see if that helps. And if there is not sufficient help, then it's time to figure out what's going wrong. So then we use the breath test, usually to diagnose whether it's SIBO or not. And if it is SIBO, then we have three treatment options that we can tend to use. So we have pharmaceutical antibiotics, we have herbal antibiotics, and we have elemental diet. And just in case anyone doesn't know what elemental diet is, it's a medical food beverage that's typically comes as a powder. It's all our nutrients that we would need, broken down into their most absorbable form. We mix it with water and we consume that for usually 2 weeks in place of meals. That becomes our meals. And so it's a 2 week course, similar to antibiotics would be a 2 week course. Herbal antibiotics is a little different. That's usually a 4 week course. It just takes a little longer to do the same thing. Now, off on the side here, I have follow a SIBO diet. We have different SIBO diets that have been created that are very successful at reducing symptoms. And we could bring that in anywhere along the line. If you haven't already started one, I usually recommend waiting until after you test. But if you've already started, don't worry. Now, after you treat, we usually put someone on a prokinetic. I mentioned about that before. It stimulates the migrating motor complex. And we're doing that just to stimulate that movement to help hold the amount of reduction we've done with our treatment until we assess. So then we assess. And if a person is 90% or more than 90% better, we consider that the goal and we can move on to the prevention phase. Now, we have a prevention phase because there are many causes of SIBO that are chronic, as I mentioned. And if you have something a disease or something that is always there that is causing SIBO, it's like you're going to relapse. How often, though, it could be a really long time. It could be like a year. It could be longer, right? That you would be in remission. But this is why we think about prevention and why it's important to think about prevention because there is statistically a good amount of people that relapse. So, what we do is we use some form of a SIBO diet. We use a prokinetic, and then there are some other supplements and other things we consider doing for prevention. And then that's what we do, and we're good, right? And we can reassess if we want to stop some of those preventions over time. Um, if a person does relapse, as I was just mentioning, then what we want to do is we want to really try and figure out what the underlying cause is if we don't know. And we want to follow the arrows around to the right and treat that relapse again with our options. Now, coming back to the bottom right, let's say a person is not better. So I'm going to judge that by they're less than 90% better. That is the perfect time to repeat the breath test because we want to reassess is SIBO there or not? Because sometimes the SIBO is actually gone and yet they still have symptoms. So that means the symptoms are from something else. This is common in that people often have more than one thing going on at the same time, right? So there can be more than one thing happening. But very often, what will happen is the test is still positive, and that just means we need another round of treatment. So, something this algorithm indicates is SIBO is a condition that often needs more than one round of treatment as its initial treatment to get it gone. And that's a key thing to know. If someone's coming in from the perspective of just thinking of an acute infection that
Hmm.
you give 7 days of antibiotics or 10 days of antibiotics or 3 days of antibiotics and it's gone, it will be confusing because for some
Yeah.
people it works like that for SIBO. You do your 2 week course and it's gone. But for so many people, they're going to need a second or a third round just to get all that overgrowth gone. And that is normal and expected. So
And
there it
not
is.
well and not well known. So I'm really glad you're saying that out loud. And I want everyone here to remember that because it's so unusual. We're so used to take this treatment, call me in the morning kind of thing, or but the multiple rounds is so important for retesting. Dr. Seebecker, how do you find it to be most efficient in terms of a time frame after treatment? And then we're going to dive into some questions.
I like it when people retest within about 2 weeks of finishing their treatment. And the reason why is because at about 2 weeks, if the SIBO is not fully gone, um, often people will begin to backslide. Their symptoms will sort of start, getting worse again. And that's just because think of it like if you were treating an acute infection and you had a 7 day course of antibiotics and you took 2 or 3 days and you started to feel better. And so you're like, great, now I stop. It's just going to come back again. Like you weren't finished treating it. So
All right.
that's why I like to retest before that point. So a little bit before 2 weeks. Anytime within 2 weeks of finishing your treatment is good. Now, one thing I just want to say is there are a lot of gastroenterologists who recommend retesting at 1 month. These are gastroenterologists who aren't like SIBO specialists per se. And I think the thinking there is they sort of want to prove it's gone. But that is not what I recommend using the retest for. I recommend using the retest to figure out where you're at with the SIBO that you've just treated, because sometimes the gases can change and you need to shift your treatment. And so you're actually using it as a treatment tool to help you get the SIBO gone.
Okay. Um, all right, let's come in for some questions for Dr. Allison Seebecker right now on SIBO in the SIBO Awareness Day 2026.
Yes, and by the way, I didn't yet thank the organizers. Thank you so much. Raising awareness on SIBO is like my life's career mission. So thank you so much for what you've done in creating this day and event.
It's a beautiful thing. Let's get it out there, everybody. Please, when you see this on social, share it. Keep, paying it forward, and let's get the word out. Can C. diff cause SIBO?
Yes, I saw that commonly before I actually realized it could cause it, and I used to just call it like post-C. diff syndrome. It's like it's kind of like food poisoning in that they have the original symptoms of the C. diff, and then it just slightly morphs. It's like as if it never really went away, but it
Mm,
got a little bit better. It kind of morphed a little bit. Yes, I have seen many people that have gotten their SIBO from C. diff.
wow. Okay. So celiacs are perfect candidates for SIBO? Question mark.
Yes, I'm sorry, unfortunately. It's common. It's a common overlapping situation. And in fact, if you're celiac or your patient's celiac and they haven't been responding to a scrupulous gluten-free diet, meaning like you've checked for hidden sources and things, so often it's SIBO that is
Mm.
making they have a coexisting condition.
I also just, while we're talking about diets, this has come up at several times here. The diets don't cure SIBO unless it's the elemental diet. Just wanted to point that out. It does, as Dr. Seebecker said, control symptoms. So you can feel much better very quickly, but it does not address the overgrowth. And the low fermentation diet, the SIBO specific food guide, the biphasic diet, the low FODMAP, all of those things are low fermentation. And so I just want to point that out because I see a lot of people in the SIBO SOS Facebook group of like 30,000 people getting very confused about that. I've been on low FODMAP for 6 months. I'm not better. Okay. That is because you still have SIBO, but hopefully you are feeling better on a daily basis because you're not doing the onions and the garlic and the apple and that kind of thing.
Well,
And
you
the
need both.
you need
You need
both,
both.
right? And the long-term goal is to expand your diet, by the way. So that's just wanted to clear that up for anybody who is a little bit, kind of not past that. Okay, let's see here. If you don't have those bacteria levels mentioned, high, if you don't have them high but have others, does that mean it's not SIBO? And I'm wondering if you're referring to a stool test, because often when you get the breath tests back, they don't label what kind of bacteria you have.
Yeah, we
Yeah,
don't, the breath test doesn't tell you the bacteria type. So, you know, what I would say is just get a breath test and then you'll know if you have SIBO or not. That's how
right,
you know.
right. Can hydrogen type SIBO coexist with hydrogen sulfide type SIBO?
Yes, we can have, I didn't mention that we can have, that there's a fourth type, which is
Mm.
mixed gases. It's very common to have hydrogen and methane together. That is like so common. But we can have any two gases together or all three. Absolutely.
Okay. Okay, here we go. I've done Trio Smart Breath Test and tested positive for IMO. Should I also do the IBS Smart Test?
I think it's wonderful to do that. I mean, I would say yes, because you can figure out if your underlying cause is food poisoning. And I think that's so helpful to know. Now, one thing that's interesting here is that the studies on the blood test show that it more often identifies, becomes positive for those that have either diarrhea or mixed diarrhea and constipation. But it can also work for those with constipation. It's just that it's a smaller percentage of patients with constipation that their cause is food poisoning. But I have to say, in my experience, I've mostly used that test on constipated patients. It's a really good test also if you really have a mysterious circumstance for the
Mhm.
underlying cause. Like you've looked at all the causes, you can see them all on my website. I have a page on causes that lists everything. I didn't say them all, and you're like, this none of this applies to me, because a lot of people don't remember having food poisoning, believe it or not. If there wasn't vomiting involved, they may not remember,
Right.
and that test can come positive. So yes, I would say it's a great thing to do.
Is it made worse by perimenopause and or menopause?
Yes, isn't that charming?
Isn't it lovely?
It's because of the hormonal changes. Yes, it can. It's been shown in particular that menopause and perimenopause can amplify symptoms of IBS. And so, yes, we see this with SIBO.
Do you see a lot of patients who are sucrose intolerant because of chronic SIBO, or do you think that that sucrose intolerant was the underlying cause?
Um, I don't see a lot of patients that have sucrose intolerance with SIBO by itself. What I particularly see from a clinical perspective without the test is that people who are intolerant to sucrose often have fungal or candida overgrowth along with their SIBO. In terms of sucrose intolerance, what comes first? SIBO could cause it. It's not common, but it could. Um, I would suspect there is an underlying sucrose intolerance. I'm talking big picture here. I have no idea what's going on in this person's individual
Dr.
circumstance.
Seebecker is not your
But
doctor,
like
and this is not
I'm
medical
thinking, yeah,
advice.
I'm thinking big patterns of
Yeah,
medicine here.
yeah.
It's not that common with
Y'all,
C.
I just want to also say, because I see a couple of comments coming in, after you do treatment and maybe you do multiple rounds, that prokinetic is key to making sure that you prevent relapse going forward. That is in the 30,000 person Facebook group that I have. That is the biggest blind spot I see. Other than people saying, like, my doctor doesn't believe in SIBO, like it's a religion, things like that. I mean, literally, Dr. Seebecker gave me a t shirt that says, "Are you on a prokinetic?" for my birthday because I
I
say it
actually
so.
did.
She
I
really did. I
actually made
almost
her
wore
a
it
t-
today. I almost wore it
actually
today.
made her a t-shirt.
But that is like if you're doing, you think you're doing everything, you've tried everything and all that, and you're not doing a prokinetic after treatment, you are absolutely setting yourself up for more frustration. So, okay, let's keep going. It's a personal pet peeve of mine because and partially because I didn't do a prokinetic because I didn't get it, and so I'm very
And she had it sitting there at her house, by the way.
don't even ask. Okay. So, SIBO Awareness Day. That's why we're doing this. Yeah. Okay. When the underlying cause is mold, 4 minutes left in this segment, by the way, Dr. Seebecker.
Okay.
It's when it is mold toxicity. How long does it take to truly address the SIBO?
We can't make meaningful forward progress on the SIBO until the mold is cleared. We can get some temporary symptomatic relief from doing treatments, and so we do that. Many people will do that, just as sort of while they're working on the mold, they'll kind of also treat the SIBO just to give themselves some relief. How long does it take to get rid of mold? I am not a mold specializing doctor, um, but it can be a while, 6 months, a year.
Yeah.
It's a thing you got to work on. And of course, you have to remediate the environment. And
Yeah.
what if
You
it's at
can't
your
still be
work?
living in it.
If
And
you're
yes,
still, or if
yeah.
you have no other option and you're going to work in a place with mold, I'm so sorry. You really have to not have the mold anymore. So
Yeah.
you have to deal with the mold externally and internally. And when you deal with the mold internally, we treat the nose. There's always colonization in the nose, and of course the digestive. And there's several pillars of it. We have wonderful colleagues that focus on mold. We have master classes on Siobhan's SIBO SOS site. You can take a look at those.
Dr. Jill Krista is one of those people.
Dr. Joe Krista, yeah.
And she wrote the book Breaking the Mold. Okay, so just think about the pockets of the microbiomes, like, your gut, your nose, things like that. That's they really hot spots for stealth infections and overgrowth. Okay, we're moving along, but I wanted to just touch back on the MMC. If someone has diarrhea, Dr. Seebecker, their doctor has told them that they don't believe they won't give them a prokinetic because they feel like their motility is already too fast.
Well, such a good point you brought it up. As I mentioned, the migrating motor complex only occurs in the small intestine. And these are two different chambers that are separated by the ileocecal valve. And even if you had an absent valve or a dysfunctional valve, there are different processes that go on from the small to the large intestine. So the migrating motor complex does not travel through the small intestine, then into the large intestine to create a bowel movement. Migrating motor complex has nothing to do with creating
Excuse me.
bowel movements. So the most common scenario in SIBO, like diarrhea and hydrogen SIBO, that's the most common presentation of SIBO. And the most common cause of SIBO physiologically is deficient migrating motor complex. So that means someone has slow movement in the small intestine, creating the SIBO, creating the overgrowth, and fast movement in the large intestine, creating the diarrhea. That is the most common presentation of SIBO. So the different chambers have different motilities. Now, a super important point here is that a prokinetic is not a laxative. Prokinetics could have laxative effects. That is possible depending upon the dose and the type. But they are not laxatives. In their definition, the definition is not to create a bowel movement. Okay, whereas a laxative's definition is to do that, to soften stool and create a bowel movement. Prokinetic's definition is to coordinate and amplify downward movement, typically of the upper GI organs. So they're used for the esophagus, stomach, and small intestine primarily. So this is the problem. Believe me, I teach at pharmacology conferences on prokinetics. The misunderstandings of prokinetics are great, and the lack of awareness and knowledge of truly the pharmacology of prokinetics is missing. So I'm so sorry. I don't know, maybe you'll be able to bring some articles to your doctor or explain this difference, but their primary effect is on stomach and small intestine.
Okay. Let's put some love into the Q&A box and some heart emojis onto the screen for Dr. Seebecker. What a great presentation. Thank you so much, Dr.
Thanks.
Seebecker. It was really, really great. There are a variety, by the way, of prokinetics, just to wrap that part up, that are some are natural, some are supplements, some are prescription. There's you can go to
You could just go to my website, SIBO Info, and
SIBOinfo.com and see a ton of it. Yeah.
go to the prevention page. You'll see them.
Dr.
Thank,
Seebecker, you're a fantastic teacher. Thank
oh,
you so
thank you. And
much.
thanks, Siobhan. Thank you for the organizers, and thank you for your wonderful questions. I loved them.
They,
Great.
they are great. Well, hang on. Don't leave yet, Dr. Seebecker,
Oh,
because we
okay.
do have a giveaway to do
Okay.
right now. And I want you to be
Exciting.
part of this.
Okay.
So if anyone wants to enter to win a free 1 month membership to SIBO SOS, which is my website, but it's where Dr. Seebecker and I have a ton of co-projects, including a 1 month that is the giveaway in this case. It's a membership where you get access to a variety of master classes, including the one on mold, and a once a month Q&A with Dr. Seebecker.
Oh,
So
yeah.
it's loaded, and that is one of that's our first giveaway today. So if you want to be, I've just been told the host and panelists can't vote. Darn it. Okay, so if you want to get a free month of that, then you do need to come into the poll and quizzes. Can we just see a couple of people pop in there, because you'd be informed after today that you did receive that, and but you do need to like sort of qualify yourself to be entered
Yeah,
to
I
win.
saw the little
I
pop-up
see
come
the
up.
pop up.
Yeah.
I just need to confirm that people can get in there and are actually doing it. So to the team, let's check and just make sure that that's happening. Yes, it's happening. Okay, great, Megan. Thank you very much. Okay, so pop in there. Lots of entries. Okay, I just can't see them, which is fine. Um, Caroline, I'm so glad you're here. Thanks, Maiden. I'm really glad you all are here and you're participating. So we will reach out to the person who is receiving that free month, and we'll look forward to seeing you there. All right, Dr. Seebecker, we're going to do another giveaway if you want to hang out. Otherwise, we're going to move along. Lots of love to you. Thank you
Okay,
so
and
much for your
love to
work.
Gary, the next speaker. Hi, Gary, love to you.
Lot
Bye,
of great
everybody.
speakers coming in hot right now. So I do want to just also, Megan, is it confirmed that I should do the next giveaway right now? Also, just want to quadruple check. Yes, yes, go. Okay, go, Siobhan, go. All right, so we're going to wrap up on that membership for SIBO SOS. And then the next one poll is, do you want to enter to win a Trio Smart breath test? And that is for USA residents only, an at-home breath test measuring hydrogen, methane, and the only test right now that tests hydrogen sulfide. It helps detect SIBO and other digestive conditions, and that is the Gemelli Trio Smart breath test. And so go ahead and register, opt in for that as well. And this is one of those times where you need to be present to win. So go ahead and pop into that poll for the Gemelli Biotech Trio Smart test. Excellent. Excellent. I'm so glad you're here. Yeah, this is fun. Yes, great, Hannah. Great. Lots of entries there too. Okay, we are moving right along. Everyone take a breath, stretch. It's a lot, it's great. And know that it's a step by step. You saw that algorithm. There is an organized approach. You are going to be able to get what you need done step by step. I say inch by inch, it's a cinch. And you are in the perfect position right now of getting this very specialized information where you can work a lot of it on your own, thank goodness, but also you can educate your provider, or maybe you're lucky to have a provider who is trained, then great. You can work in even more educated fashion during those appointments with that provider. So thank you, thank you, thank you for your participation and being here and taking good care of yourself. I mean, you're making your own luck by being here. So that's very, very exciting. Okay, as we wrap that up, we are going to be moving along right now at the top of the hour to a personal friend of mine and certainly to the community, and that is Gary Stapleton. Hi. Hi, Gary.
Hey there. Good to see
Hey,
you.
oh my gosh, you are tan rested and ready, sir. Look at you. So good
I,
to see you, Gary.
Thank you. I don't think I look like that in person. I swear.
Get those filters going,
It
man. Get
does
the filters
not
going.
look like that. So I always
Well,
get that when I'm on Zoom, but I do not look that dark. But anyway,
well,
thank you.
maybe you
Okay,
have
Dr.
that
Seebecker.
filter adjusted. All right. Well, Gary Stapleton is the CEO and founder of Aero Diagnostics. With years of industry experience in laboratory diagnostics, Gary now brings clinically proven, okay, SIBO breath testing to patients and providers nationwide. Gary, I
International.
say it again,
And
internationally.
yes, 42 countries. Yeah.
42 countries. Okay, then. Let's get that one right for sure because I know we have a lot of people internationally watching. That's fantastic.
Yeah.
Gary, you are one of the most passionate, dedicated people to this cause. So it's so appropriate to have you here on the SIBO Awareness Day. And ever since I met you about 10 years ago, you've just
Mhm.
really continually demonstrated your commitment to making sure that patients and practitioners have the information that they need. So it's a
Thank you.
delight to have you here. And I've got some hot questions for you, sir.
That sounds great. If I may, I just want to say one thing about that. I think the passion actually comes, and it's with you and Dr. Seebecker and Eric and the whole team and Quintron that are listening in, by the
Love,
way.
love,
You
love.
know, they're
Love me
on
some
they're
Eric.
on.
Yeah.
And this is about patience. And that's why every time I speak, now these are some canned questions, so we may not get to it, but it's always about matching the clinical impressions that are presented from the patient to the gas data. If everyone does what they're supposed to do, from the proper prep to the use of a very good closed capture kit to the preparation, then to the laboratory work that you do, and then the interpretation, it always should match. Because if you do everything the right way, using the right equipment and the right kits, it's binary, gas, symptoms. So anyway, that's why I say that.
Okay. All right. That's very, very hopeful. Seriously. Okay.
Yeah.
We are going to get into the breath test mechanics. Okay.
Mhm.
What is a breath test and who is a good candidate for one for SIBO?
Sure. So there are many different types of breath tests. In particular, what we're talking about here today are SIBO breath tests. A lot
Right.
of breath test laboratories do other types of breath testing, like we do intolerance testing, like lactose, fructose, and sucrose. But primarily, today is about SIBO. There are other breath tests that have nothing to do with SIBO. So we're going to qualify the question that the breath testing that we do is we're measuring gas to determine if there's fermentation at a certain point along a 3 hour continuum. And we recommend the 3 hour test. Not that the 2 hour test is bad, it's just that we recommend it's kind of gold standard. And for many reasons I won't get into here. But the breath test helps clinicians validate what they suspect, whether or not they're ruling out SIBO or whether they want to confirm it. Why? Because SIBO can look like a lot of things. You were just talking about one, mold, fungal, Lyme, parasites. So we need to know for sure that we're dealing with SIBO. You don't want to just assume based on symptoms, oh, I bloat all the time. Okay, let's start treating. And then it's thousands of dollars later. And guess what? It had nothing to do with SIBO. So we need to know that, but we also need to know if there's methane present. Because if there is methane present, then the choices are different on treatment, right? If you're
Right.
using herbal microbials, you're going to use, whole garlic, right? An allicin, right? If you're using antibiotics, you're going to use combination antibiotics, right? If you have other kind of symptoms and you many times, not all the time, many times you don't have hydrogen or methane gas, but you have symptoms like peripheral neuropathies, intolerance to lighter peripheral neuropathies or tingling, numbness, hands or feet, issues with lighter noise, interstitial cystitis, which is bladder irritation, burning urination,
A nightmare.
fibromyalgia, yep,
A
body pain,
nightmare.
body ache,
Yeah.
and then the gas that smells like sulfur. So you'll know you're dealing with that. And those questions come from the great work that Dr. Seebecker did many years ago. And the reason you have not only the SIBO symptoms, but you have some of these sulfur symptoms as well, is that hydrogen sulfide works through the nervous system. So that's why you're getting that. So
Mm.
you can validate, and yet you'll treat differently for that as well. So who's a good candidate? This is the most important thing that I try to convey to everyone. With SIBO patients, if you have, so you have your GI tract, right? Your mouth, your throat, your stomach, this 23-foot plus tube. It looks like spaghetti if you've seen anatomy. And that's the small intestine, right? And then you have your colon, and then food exits the body. Well, the small intestine isn't sterile, but it's nearly sterile. The technical terms is 10 to the 3 colony forming units of bacteria. So it's very, very little. The colon, however, is more than 10 to the 12. So you have a lot of bacteria in the colon doing its job there, but not supposed to have a lot in the small intestine. So what happens? Maybe from food poisoning, maybe from a compromised ileocecal valve, that doorway between the small and large intestine that Dr. Seebecker was just speaking to. Maybe that's compromised, so the bacteria is coming up. When you get an abundance of bacteria or archaea, on the methane side, then what happens is when you eat, you feel symptoms. It could be bloating, cramping, nausea, not gut rate, joint pain, restless leg syndrome, rosacea, and some others. But
Yeah,
the key is the chronic nature of it, right? It can't be intermittent. If you think about it, if you have bacteria in that small intestine, it doesn't care if it's Monday, Wednesday, or Friday. It doesn't care if it's morning or afternoon. And it really doesn't care about the food. Yes, some foods are more highly fermentable,
sure.
clearly, but
Yeah,
you're gonna have symptoms all the time. So who's the candidate? The patient that presents and has this, some of these, a combination of these all the time. And that's when we want to validate that it definitely is. And if everyone, as I mentioned earlier, does the right thing, we'll know for sure because the bacteria, I mean, the substrate, whether it be glucose, lactulose, and some are even using fructose, that's a food source. It's all it is, just a food source. So it goes through the mouth, the throat, the stomach, and then when it gets into that small intestine, if there's bacteria there, it's not going to just step aside and say, "Yeah, go ahead, bye. I'm not going to eat you today." It has to.
Gary, I would know we could go on and on about who
Yep.
it's for, but that covered it really
Yep.
well. I want to ask you,
Yep.
how do we obtain the test? Does
Mhm.
my PCP have to order it? Do they need to be a GI? Like, tell us about some of the logistics.
Absolutely. And please feel free to stop me if I keep going on.
Uh,
The, so
I'm your girl, man.
Very, various labs will handle it differently, but in
Yeah,
general, anyone can order a test, a SIBO test, not with lactose. We're going to get to that in a minute, but you can order a SIBO test with glucose. You can order it directly yourself. We don't recommend that. We recommend working with someone, but you can order it directly
sure.
yourself, or you can order it through a clinician. You can order it through a dietitian, a naturopathic physician, an MD,
They
ND.
just have to register with the lab, right?
They just,
That
yep.
person, that practitioner. And what's so cool is we can order it directly as well. I like the idea of walking into that next appointment with the test in hand. But
Yes.
if you also, like the very first test I had done in a doctor's office, I was totally clueless. I was glad I had the first test done in a doctor's office. I sat in the
Right.
reception area for like 3 hours. However, the famous story is they crossed out the word positive and wrote the word negative because they didn't know how to interpret the test.
There you go. Yep,
So,
that's exactly right.
yeah.
And there's a lot more that goes into that too sometimes. You really have to know that you're using the right equipment, the right collection kit. It has to be closed capture. If you're opening things up to room air, I,
It's not going to work.
not from my perspective, it
And
wouldn't.
are they calibrating the machines? That kind of
Right.
thing. So this is part of the whole,
To known gas values, not
right,
algorithms, to
right.
known gas values. So there's a tank in our laboratory, and the technician, you'll see 4 blue trays and a red tray, and the person's samples are each in trays, right? When they get to a red tray, they have to stop the machine. We do it every 5 patient tests, way more than we should, based on what the
Yeah.
manufacturer suggests. But we do that for accuracy.
So another question is, what about insurance? Does insurance pay for it? And how long do the results usually take?
Just trying to be funny here. Insurance doesn't pay for anything anymore, but I'm joking. It,
Ouch.
I know,
Right?
but honestly, yes, there are insurers that do pay. Some pay part, some pay in full. It depends on a lot. It depends on your policy. Like right now, it's deductible time. What do I mean by that?
Right.
As you know, January 1st comes around, you reset your deductible.
Right.
So until you clear that, even if they pay, and this is the problem, because you'll call your insurer and say, "Whoa, will you pay for this CPT code, right?" And they go, "Yes." And then you go and do the test, and guess what? They say they declined it. And you go, "Well, you said you would pay for it." Well, but you haven't hit your deductible. They didn't
Right.
finish the sentence. So just check. It's always a good thing to run your insurance if you have it, because they may pay something. If not, it goes toward your deductible. So it's a good thing to do.
Yeah, let them know that you've done it. And what are those codes, Gary? I'm sure you have them off the tip of your tongue.
Yeah, they're actually, let me just step away because
Okay,
they get very specific too, because there was a change back about
let's
2 years
see.
ago. So it's hold on a second here. Uh,
This is just for reference. You guys can Google this, but I just thought
yeah,
we have him, so why
yeah, it's
not?
yeah. Actually, I was looking for well, it gets really complicated, but it's 91065s, but it's what they need is the ICD-10 codes like the K63.82,
You're gotta go slower
81.
because everyone's writing it down, Dan.
Oh,
Go
okay.
slower.
Yeah,
I
so it's K63.82,
K
and then
six three. Wait, K
K63.82,
63.2. Okay. Oh,
point
point
eight
eight
two,
two. Okay.
and then K63.821,
63.821. Okay.
and then K63.8211,
3.8211. Okay.
K63.8212,
K, I regret this already. K63. Okay.
uh-huh,
K63, what now?
point 8212,
0.8212. Okay.
and K63.8219.
0.8219. All right.
Okay, now there's two more. I just want to tell you, one is for CFO, and that's K63.822, which
0.822.
is
Okay.
not measured on a breath test. I'm just
Yeah,
telling
he's
you,
just giving us some
yeah.
codes, folks.
And
Just
then
trying to help.
the last one for intestinal methanogen overgrowth is K63.829.
63.829. And that's
Yeah.
emo. Sorry to like break in the
Yep.
action there, but I just wanted to
No
make
worries.
sure if anybody wanted those, they could get it. And I'm just going to take this and put it into the Q&A box to yeah,
Yeah,
and
and
these codes need to be verified by your insurance company. Totally. This is not a
absolutely.
guarantee. This is just like a step in the right direction. The whole thing is, right, it's awareness and it's data.
Mhm.
So just like a SIBO breath test, it's data. And these codes may help you. I would confirm them with ChatGPT or Claude or whatever, but because I know, hopefully I got everything right. But it's data, it's support materials, and um,
The
what
other thing I will say about the codes, don't be surprised. You're not going to be able to go to your clinician and say, oh, you need to use these codes because that's not legal for them to do. They're going to determine what
right?
code appropriately fits what they
Thank
suspect
you.
you're dealing with.
Perfect.
Uh-huh.
Gary, did you say that SIBO can't be measured on breath test? No, that's the
No,
whole that's
no,
the
no,
whole point.
no.
They can't
Oh,
it
yeah,
can't
yeah, yeah. No,
yeah.
what I said,
What
CFO,
CFO. Okay,
fungal.
Vanessa, thanks for clarifying. Where did
Yeah.
the codes go? I don't know if the team wants to open up the chat just to pop those into the chat. I will let them do their thing. We're moving on. Cheryl, we'll figure something out for you. Okay, we're gonna go and continue with the questions. Gary, how long does it
And,
take to
I'm
get
just
the
going to
results?
say
Okay,
CFO is fungal overgrowth. Just that's why it sounded when I was saying fast, it may have
yeah.
sounded like SIBO, but CFO fungal overgrowth. Okay, go ahead. Sorry.
Okay. Hey, Megan, I just popped it into the. There it is. It's in the chat to host and panelists. Okay. How long does it take to get the results
Well, it depends on who you're working with, right?
on average? On average.
Well, I'm going to tell you, this is a pet peeve for me because I come from anatomic pathology where we did skin biopsies for cancer. So I return in 24 business hours. It's just my rule. It's what we do. Um,
Okay.
but there are some labs that are up to a couple of weeks. I'm not judging them. They're much bigger labs. They have a lot of things that they do. Maybe the processes, I don't know the processes. I'm not saying
Right.
that's a bad thing. It's just I'm passionate about you've done a test, you've already put it in the mail, so you're at least a day, if not two. The minute we get it, it's 24 hours, 24 business hours.
Okay. For
Have it.
turnaround.
Mhm.
And then how long should I not take treatment, antibiotics or probiotics before doing a SIBO breath test?
Okay, so you're going to have a lot of different answers to this. So there's a lot of information out there. The information that was the basis for all breath testing that comes from Dr. Lyle Hamilton always said, always referred to 10 to 14 days, 14 days, that range. However, and why? Why retest after, why test after antibiotics or herbal antimicrobials 10 to 14 days? Because you don't want the effect of it. We want to see if there's bacteria there after treatment. You don't necessarily want to go the next day, although I'm going to tell you something, Neurolo would disagree with that. And
Yep.
then, yeah, and then, other people will say wait 4 weeks, which I just disagree with because, and many of my clients, I don't know one client that would wait 4 weeks because then you have regrowth. What if you
Right.
don't get it all? It's like the weed in the root. And that's a reason for retesting too after treatment. You'll feel better potentially, but if you pull that weed, but that root is still there, you're just going to, oh, the SIBO is back again. No, the SIBO isn't back. It just never left. Now, some clinicians, I don't want to speak for Dr. Jacoby, but I know her very well, and she
We
has made
love
the
us
case.
some neurology, Kobe.
Yeah. And she made the case, hey, it's either there or it's not. So I test the next day. Dr. Morstein is like
Mona
5 days.
Morstein,
Yep.
lots of
She's
love.
5 days. Yep. And then most I would say is 10 to 14 days.
Right.
However, and I know my lab does this. I don't know if other labs do, but if you are being treated with elemental diet, now for those of you that don't know, elemental diet is the liquid diet that you drink. You can do it a combination of eating and drinking, but most are just the liquid diet for a period of time, 7, 14, 21 days. And it's meant to feed you, but starve the bugs. That's not like a low FODMAP diet or some other diet. This is designed to, kill the bacteria and the archaea.
Yep.
So
Here's one
when
of them
you,
right there.
there you go. So when you do that, if you let us know that you're on elemental diet and if plan it so that you technically finish, you're still going to stay on it for a minute, but technically finish on a Sunday or a Monday, then you collect your breath after just 12 hours. You don't go back to the prep diet, just 12 hours of a water fast. Now you collect your breath specimens. Let's call it Monday morning. So you finished Sunday night, 12 hours overnight fast. Now you collect your breath. Our shippers, we give you 2 day shipping through UPS. However, if you wanted to overnight it, you could. But
Yeah.
once you finish, you're back on the elemental diet until we get you your answer. And we're going to go faster than 24 hours for you. If we know it's inbound, then when we receive all the boxes, we go through it. And if we find an elemental diet patient, they go right on the machine. So within 2 hours or so, you have your results.
I think a lot of people think, you call LabQuest or LabCorp Quest or whatever, and like you usually don't get a person. But with
Mhm.
Gary and the other labs that are typical for the SIBO breath testing, they're actually real people that are, most of the time going to pick up the phone or you can fill out the form online. I've heard that they're calling people. So it's much more, I think, interactive than what we usually think about for a lab. So
Yeah.
thank you. If people,
Yeah, we outbound call when we get an order, we ship the kit. Well, we get the kit shipped,
yeah.
then we give it a day or two, and then we're outbound calling patients just to see if they have any questions, if we could be of any help.
Oh, that's so
Hmm.
so great. So
Yeah,
that's like real legitimate customer service.
yeah.
So and also a very important detail if you are doing the elemental diet. Can you be on Prokinetics and do a SIBO breath test?
Prokinetics were removed a couple of years back, maybe even more than a couple of years. Or probiotics were removed. Prokinetics, the studies haven't been done. There's so many new products, so we can't say. The best rule of thumb that I give is any gut-related product, if you don't absolutely have to be on it, try to discontinue it for a couple of days up to a week before, if you can. Secondly, I know my lab, I can't speak with others, but I'm never going to tell a patient what they can be on or off. That only comes from the clinician.
Right.
So
Yeah.
I'll talk to the clinician about it, but I'm going to give you and your clinician a picture of what you give me. So if you give me a small intestine that has a bunch of products on it, that's what you're going to get an answer on.
Right.
Okay. If
Right.
you if you're just your body acting as your body, we'll know if there's bacteria or archaea there definitively if you prep right, use the right kit, and so on.
So if you figure out that you're a candidate for a SIBO breath test,
Hmm.
You can reach out to the labs that we've been talking about. You can do the test at home. There is a prep diet to do, and that's all explained in the box, and on their websites. And then you do the test, you send it in. Be strategic about what day of the week you send it in if you want to get those results back very quickly, especially if you just finished the elemental diet. The elemental diet acts as the prep diet, by the way. And
Hmm.
then you can reach out to Aero Diagnostics, for example, and they will rush your test results to get that to you. Now, Gary, can the patient receive the test results if it was ordered by the patient? I would imagine that answer is yes. But then if the doctor ordered the breath test, do the results go to the doctor?
So if you're a patient and you ordered it, you're getting the results. If you want it
Okay.
sent to your clinician, you just tell us who to send it to. If your clinician orders the test, then the results are going to that clinician. And
Right.
likewise, the clinician can say, please also send it to the patient. But somebody has to do it. If a clinician orders it and you just call in, our team is just going to call the office and ask them if it's okay because that's how we have to do it. It's your data. You have a right to it.
Right.
And if push came to shove and I was confronted with a clinician saying no, but a patient saying they want it, the law is the patients can have it. So I end up sending it and unfortunately upset a clinician, but I think that's only happened once in 12 years, 12 plus years. Yeah.
Yeah. Right. Exactly.
Uh-huh.
Okay. Should you always use the same test from the same place?
Not necessarily. I mean,
Okay.
I would like that because it's continuity of service.
Sure.
Because you're going to have there are different preps out there, and that is by far the biggest reason you have bad results. If you don't have a really good prep and really understand what that prep is, you can't use very high vague terms. The way we teach it, what's on our website, and if we're on the phone with patients, it's chicken, fish, eggs, turkey, white rice, white bread. There are going to be others that say lean meats. There are going to be others that say tofu. There are going to be others that say carrots. Okay, but from my perspective and the work of Dr. Lyle Hamilton, which has consistently given me results, and the one thing I hear all the time is your results always match with what I expect, and it starts with the prep. And
Can
so
you
I'm
do
just
eggs,
highly
Gary? Gary,
strict.
can you do eggs as a protein
Yeah,
source?
yes, I'm sorry. I
Yeah, I
just
just
was,
want to throw in eggs because I'm a
yeah.
vegetarian, so I
Mhm.
like to mention that.
Yeah.
Um, so Gary is a purist, right? That's what you want in a lab owner. You want a purist, trust me. Okay,
Yeah.
can
Well,
are there
show me the study that said that the prep with some of those other items worked, and show me a patient that understands what lean meat is, right? I mean, there's going
understood?
to be some, but not everyone.
Yeah,
You
understood. Where can the
know?
tests be ordered? So you can go to Aero Diagnostic
Mhm.
Labs online. You can go to TrioSmart online, Gemelli Labs.
Mhm.
They're floating around in the sponsorships, et cetera, around here. You can simply
Yep.
Google, where can I get a SIBO breath test for home? This is all of that awareness. That's what we're talking about today. So great. And
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 you can
Dr.
also do it in
Seebeck,
your doctor's office, right? If they
yes.
have it, but are they
And
calibrated and all that?
right. And Dr. Seebecker has a list of labs too
At
on her site.
SIBOinfo.com, right?
Mhm.
I'm sure SIBOawareness.org also does.
Yep.
Okay, so let's get you a couple of questions here. Can
Sure.
you test positive for hydrogen and methane and not actually have SIBO? Interesting.
Yes, I'll tell you how. When you don't do things the right way. Like if you
When the
don't
prep isn't
calibrate a
right.
machine, you don't
Okay.
calibrate a machine, you
Ah,
don't do
okay.
the right prep. So let me just drill real quick.
Yeah.
If you don't prep, you have a big steak the day before, but it was a lean steak, right?
Okay.
Now it's in your colon. Remember what I said earlier? There's a lot of bacteria in that colon. Do we really think that's going to be out by the next morning when you wake up? More than likely not. So now you have all this gas, and we don't know if it's small intestine, large intestine, or a combination.
Okay. So sticking
Short
with
answer is yeah.
yeah, right. Sticking with the instructions are very clear, and also take a minute to absorb them, but just step by step, and get your timer. If you're doing it at home, get your timer out. I know that when I've done the lactulose in the past, which is that one of the sugar substrates, it gave me a lot of brain fog, and like it did not do well for me. But I actually got the timing wrong because the brain fog got so bad while I was there. It's so
Yeah.
I also recommend doing a timer that's not your phone because like you take a call, you send a text, that timer, wait, what happened to that timer? So get the kitchen timer out and do it that way. What's the range?
You would be shocked about the brain fog. We actually get kits back with the lactulose or glucose in the kit. They never even drank the substrate.
Yeah, you have to really hone
Yeah.
in on those instructions.
Mhm.
What's the price range for testing these days, Gary?
Yeah, it does range quite a bit, but I would say generally speaking, the 230 to 370
Okay,
range. But it can change if and that's cash
just
pay.
depends.
That's
Right,
cash pay.
right.
If you're filing an insurance claim, you're going to see an EOB, explanation of benefits, and you're going to see invoices for much, much higher. Don't shoot the messengers. This is just insurance billing 101 for the United States of America, unfortunately. You have to bill at a certain percentage above, Medicare, and then it gets all knocked down. At our lab, if you get an invoice and it's much larger than the cash pay price, there's a giant red arrow that says just pay this amount if you pay within 15 days. And we always forgive those that don't, that kind of thing. Um, but don't be afraid if you use your insurance. You want to use it, and don't be afraid if you see an EOB or an invoice. It's just I can't speak for other labs, but we give it to you for the cash pay price.
Communicate.
Um,
I think that's the key. Yeah.
yeah.
Okay. Do you need to have someone help you do it at home? It is kind of stressful. There are videos on the different labs' websites. Um, yeah. I mean,
Unless you're a minor, I would
you
say
don't
it's
need another.
very, very simple. However, like you said, you're already kind of anxiety ridden if you have SIBO. So why not
Yeah, if
have,
you can have a helper, by all means, it's great.
yeah,
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 but
or
but it's not essential. It's really not
no.
essential. You can ground and get focused and
But
step by step.
yeah,
Yeah.
if you're stressed over it from aerodiagnostics, you just call us. I can't tell you how many FaceTimes I do a week
Oh,
just helping a
fantastic.
person, get the first couple of specimens in, and we'll FaceTime with you.
How about FSA? Is the
Mhm.
SIBO test FSA deductible if we pay cash?
Yes.
Okay. All right. If my breath
Check with your
test,
plan. I should say check with your plan, but
that
generally,
it's just like everybody's results are going to be different with a supplement and a drug and all
yeah,
that. Like, check with your
yeah,
plan.
yeah.
If my breath test comes back negative, but I still have symptoms, what should I ask my provider about next?
Well, it's pretty
That's a
broad because,
huge
like we
question.
mentioned, you could have, mold, fungal, Lyme parasites. The test result could be wrong. The
Yeah.
interpretation could be wrong.
Yeah.
It's really broad. It sounds like that's coming as a very specific
Yeah. I think
thing.
that
Like,
happened to someone.
yeah, yeah. And if you have your test result and you want your clinician, if they want to talk with me, just send us a message. I'll review that along with the clinical and we'll talk about it and see
Sweet.
what, if anything, could have gone wrong.
Okay. How accurate are the at-home breath tests compared to ones done in a clinical setting? Is one more reliable?
I think again it goes back to are you using a closed capture kit, right? Or are you opening up test tubes or bags or whatever it may be to room air? That's one. That's one thing. Did you prep right? The accuracy, I know I sound like a broken record, but the accuracy has everything to do with did you prep correctly? If you did you use the closed capture kit? If you did use that and you prepped correctly, now you send it to the lab. Is the lab doing calibrations to known gases, not an algorithm?
Okay.
Um, and then did they interpret it right? So it can be very, very accurate and it can be very, very bad. In the early days, you say, yeah, a lot of the clinicians would say when I was calling them to try to start the business, oh, those breath tests are always wrong. And you know what? They were right. They were wrong
But
because they were
not
proving it
anymore.
wrong.
This is
No,
the test tubes, for
absolutely.
example, with the Quintron machine. So what he's talking
Happy
about with
birthday, 65. They're
happy birthday.
65 years old
Oh, happy
this year.
birthday. That's
Yes.
amazing, Quintron. Way to
And they're
go.
on here. They're listening.
Yes, blessings
Yeah.
to the Quintron folks. The thing
Yes.
is that this is the closed capture. There's a device here. I just wanted to show you what he's
There you
talking
go.
about.
There you go.
Thank you, Gary. There you go.
There's so it's like a vacutainer. It's like when you go for blood draw, you puncture and they keep slapping, switching the tubes in and out, the
Right.
test tubes, but you're not punctured by this. So in one part is the mouthpiece, the other part, there's a needle. Here is your closed crimped, vacuums, evacuated test tube with application notes that tell you this has been studied to do the right job. Now you just exhale normally. Simple as that.
It's a
Couldn't
normal
be more
exhale. That's
simple.
such a good point. It's not like a big, I'm going to blow up a balloon, guys.
No, if
It,
you do this, if you go, what you're doing is you're bringing room air into your lung air and that's mixing it up. But we measure carbon dioxide to be sure that the contents of these tubes are consistent with true human lung air, not room air, dead air, mouth air, space. That's how we will know for sure.
okay. I think we already talked about that. Should we wait 2 weeks after finishing herbs or antibiotic treatment before doing SIBO breath test?
10 to
And
14, if you're asking me,
okay,
but there are other people that have other opinions.
okay, that's
I
fine.
found consistent results with that.
Okay. Can these breath tests be shipped to Canada? If not, what should I look for in a breath test? What kind of lab to look for? You ship to 42
Okay.
countries.
Yes, you can ship to Canada, but the trouble there is getting the lactulose in and out. So it's over the counter in Canada. So just order a no substrate if you're ordering from us. Order a no substrate kit, and then just pick up lactulose, 10 grams of lactulose at a local pharmacy,
Okay.
um, and then use that there.
So we're gonna take on the hot topic. Are you ready?
Oh boy.
Let's talk substrates, people.
Yep.
Go,
Yep.
Gary. Go, Gary.
Are we? Is Dr. Seebecker off?
I don't know. I don't know if I can
All right.
handle it. Yeah, no,
Okay. The way
no,
I always
she's
describe this is
okay.
if you're at a health meeting about SIBO, if you were to throw a rock into a crowd in any direction, you're going to get a different answer, right? Those that love glucose say that lactulose is bad. You're going to get false positives because it increases the rate at which it goes through, and you'll get a false positive. And there's some truism to that if you don't do what we do. But just that aside, if you're a lactulose fan, you're going to say glucose is absorbed in the first two feeds, so you're going to miss this, or it doesn't feed certain bacteria for this. Um, I've had 12 years, over 100,000 tests. I have given experts, five patients each, both where they would do a glucose on one day, a lactulose on the other. And I did it for five different SIBO thought leaders in one office, and they each had five patients, and all of them came back the same. If you do everything right, it's going to be now. There are going to be people that disagree with me on this. There just
Yeah,
are.
it's fine.
But I think both are very good, and there are good reasons to use glucose because there are a lot of clinicians out there that don't have access to lactulose in this country. So we need something for them. Um, but it's just that's my opinion. There are going to be others that feel differently. I wouldn't offer both if I didn't think both were accurate.
Oh, right. Okay. Can you have all three, EMO, SIBO, and ESO, tested for EMO and SIBO and negative for ESO? But first time I hear about the bladder symptoms Gary mentioned, I want to say something, which were present during my flare up. So I was wondering if I missed it on a 2 hour test. You can have an overgrowth in the bladder from so many other things. And that terrain between the whole urogenital and digestive area, it's all very they cohabitate in many situations. I do recommend going to Microgen DX, which is a lab where you can test for very specific overgrowth in urine
Mhm.
and vaginal microbiome. So check out Microgen DX if anyone here has chronic UTIs and interstitial cystitis. So I don't think a SIBO ESO breath test positive would mean that you have a bladder scenario. So I just wanted to clarify that.
Yep.
Okay.
I would agree, but it's not really my
That's not your
position
gen-
to
that's
say.
not your microbiome.
I know the answers, but it's not really right for me to speak to
Is
that.
there a study that shows that ESO is associated with IC? Is there a
All
study?
right.
Yes or no question,
Here's
Gary. I setting you up
hold
for
on a
the
second. Hold on a second. Let me get cynical Gary. All right, here he is.
okay.
Um, I worked for large pharmaceutical companies for many, many, many years, and
Yeah.
you can get a study to say anything you want.
Oh, okay.
Sorry.
That's sad.
It's
No,
true.
that's that's the voice of experience right
Look,
there.
I
Cynical
just want to
Gary.
say, look at statins. It's ridiculous. Taking a statin isn't going to reduce 25 to 30%. If you've had a hard heart event, yeah, but if not, it's 0.0005. And you got billions of people, millions of people on statins. It's crazy.
Gary, tell me how you really feel about it.
What brand is this? Telling you.
I'm with
Jeez.
you. What is
Jeez.
ISO? I missed it. It's the hydrogen sulfide version of SIBO. So it's the overgrowth of organisms producing hydrogen sulfide. So just to, so we're using the term umbrella-wise SIBO for the overgrowth of methanogens, of hydrogen producers, and of the hydrogen sulfide producers. Okay. Let's see here. We've got that. We've got that. We've got that. Renee is giving you some feedback. It'd be awesome if the test came with a trial, something that I can try out first before actually breathing into the official container. That's how she felt as a first timer, like a practice set.
I I actually think, and I wish Eric were on here because I think at some point in the history they actually did do that. I might be speaking out of
It might
turn,
have
but I think
increased
they may
costs too
have.
much.
And
Yeah.
then if I rem oh, this is cobwebs now. I think it was confusing.
Yeah. They're like, hey, I thought there were supposed
So,
to be this many vials. What's this extra?
and even if you write it,
Yep.
the whole thing in, writing medical terminology and instructions and stuff, you're supposed to write it at like a sixth grade level, just because people get confused. They have brain fog in this case. And I can't remember the story. I'm gonna have to ask him about that after I've forgotten. Sorry, Eric.
Eric, you can text me. Anyway, oh no, my phone is off. Anyway, let's take a breath. Is what no pun intended.
Yeah.
Gary, what else in this final moment do you want people to know?
Thanks for that question. Breath testing can be very accurate. You've heard me say this over and over. We really need to test before you start to treat to make sure that you're not treating unnecessarily because it can be very expensive and it can be harmful to you. So you don't want to do that. Um, Ask the questions, and if everything should match with what you're experiencing. If you have chronic, meaning all the time, every day, all day, any time of day when you eat or drink, you're feeling this way, it's likely to be SIBO. Have a clinician determine that with you. Get a test, and if you do everything right, you'll know for sure, or you could rule it out.
Hmm.
But the most important thing to me is not over treating, and I think we've gotten this down. A lot of labs doing a lot of good work here.
Great. That's a great way to sum up. And remember that SIBO imitates so many other things, from ovarian cancer with bloating to candida, parasites. So it's this whole premise of test, don't guess. And thank goodness these tests have come to the point of where we can do them at home. They are within the realm of being affordable, and that the science is there, the validation is there. A whole lot of work has been done for the validation,
Absolutely.
and
Absolutely.
there are a lot of,
Absolutely. Yep.
this is like, there's still, I see random comments, crazy pie, like, oh, the SIBO breath test, blah, and just it hurts me because maybe that was true 25 years ago. Okay, I don't know,
Yep.
but the science has, there was a wave of that, and so the science has been very diligent.
Yes.
The scientists, people in
Hmm.
labs have been really really diligent about saying, well, what is the truth? And
Right.
that's where they are now. So that's very exciting.
Yes.
Okay.
Uh,
Okay. Any fungal testing can be done with breath testing. I think we already covered that, but
yeah.
go ahead
We'll
and
come.
pop that out to the world, and then we're gonna take a little mini break and do a giveaway.
All right.
Can you do a fungal breath test? Does that exist?
I'm not aware of one that I would think would, if there is one that would be accurate, but I could be wrong on that. I'm not
Okay.
familiar with one.
Gary, do you find that when SIBO in all its forms are cleared, that the fructose intolerance also tends to clear?
It's hard to say because no one has really looked at that and done,
Okay.
work with enough patients to determine that. Um, But we've always reported on fructose, lactose, and sucrose tests. If you have early gas, we've always reported because the data is there, again, from Dr. Hamilton, that would say, hey, this, if prep or prep was followed, that could be SIBO. And if you have third hour gas, that's the intolerance. Now you're asking if you clear SIBO, is that it? I can't answer that because
Okay.
I don't have a study or like I said about studies, but the what any real good SIBO thought leaders would say is clear SIBO first. And
Right.
what I say is clear SIBO first, and then if you're home on Saturday or Sunday, when afternoon, have a little bit of fruit, or if it's
Right,
sucrose intolerance, have a little bit of sugar. How do you feel? Do you run to the restroom? Then
right.
you can retest for the intolerance.
Great, 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 great. Okay, while you're still here with me, let's do the giveaway. Who would like to enter to win a Quintron and Aerodiagnostics premium bundle? So, Quintron is the manufacturer of the machines that are used at Aerodiagnostics, and they're partnering during IBS Awareness Month and Quintron's 65th anniversary family run business. One winner in the USA only, no PO boxes, will receive a premium bundle including 3 co-branded Aerodiagnostics Quintron breath test kits, SIBO glucose, lactose, and fructose, plus 2 SIBO cookbooks. I'm taking those are from our friend Rebecca Coombs. Gary, is that right?
I think so.
Okay. USA only, no PO boxes. All right. I know that the
Can I tell
team,
you why on that? It's
yeah.
because UPS doesn't deliver, and nor does FedEx to PO boxes. That's the only reason.
Yeah, I know you're not being a pain in the booty.
No, but oh
Yeah,
no, how come?
yeah,
That's
right,
what I get my
right.
email.
No, I understand. I understand.
Oh, and
Okay,
there's a reason why they're 65 years old.
yeah,
A lot of companies don't make it.
please. That's exactly right. We're talking about generational commitment to the bigger picture and the cause.
Absolutely.
So,
Yeah.
and Martina, just want to confirm that the poll is working well and that we are getting a lot. No, you know what? It is working. Hannah is saying it is working. Annette is having a hard time saying her chat is disabled, so she wants to be able to enter. So I'm going to let you all handle that with Annette. Annette, my mom's name was Annetta, so I always get a God wink when I see someone named Annette. It's close enough for me. And let's all just take a stretch and a breath while we are filling out that little poll. And just wanted to say, Gary, thank you so much. Thank you to Quintron. Thank you to Eric, who's leading Quintron these days, and to you for Aerodiagnostics being such a highly committed and high integrity
Thank you.
lab. What a great
Thank you.
partnership.
And thank you for your commitment to these
Oh,
sufferers worldwide. It's been quite a decade, huh?
quite a decade. Yep. Yep. And still going strong, still going strong.
Absolutely.
So thank you.
Yeah.
All right, Gary,
All
thank you
right.
so much. Let's pop some
Thank
love
you.
into the computer Zoom sphere for Gary. Gary, thank you, thank you,
All
thank
right.
you.
Thank
Mwah,
you.
mwah.
Thank you.
All
Love you.
right. All right. Take care. All right. Someone says it doesn't work on the phone. Okay. Maybe that is true. Maybe you have to be on your computer. Yes. I don't see the poll. Someone says so that may just be the case. That is a bummer. All right. Unintended consequence right there. But we are going to keep going and we've got a lot more still to get to. So if you need to do a stretch, take a bio break. There's like a 2-minute pause right here before we get to our next speakers. I know it's not very long, but I just want to make sure everybody is super, super comfortable and that you're absorbing this and you're not getting overwhelmed. And I'm sure that you are going to get the replays. And again, when you see it on social out there, please forward it, send it off to your friends. Brian's saying that it is working on his phone and he's on the road. Okay, so the Zoom settings, sometimes there are differences. You might not have the latest version of Zoom. I find that to be also kind of a barrier sometimes to getting what we need to have all the tech work really, really smoothly. We have a couple more questions here. I don't know if, um, let's see here. I'm just checking with some logistics here. Yeah, so maybe, okay. Alana is going to be joining 10 minutes before 12. Dr. Ivanova, Ivaneva, thank you. So maybe she can get some questions going. Okay. Chat's disabled. So there's a little bit of a tech thing with the poll, but hang in there with that. Okay. So how do you treat leaky gut? What's the treatment for leaky gut? Hi, Penny. One of the things for leaky gut is that, as Dr. Seebecker said, some people with SIBO do get leaky gut, and when you clear the SIBO, often leaky gut clears, which is so exciting. One of the supplements that I know often is suggested for leaky gut is butyrate. That's one of the things. There are some tests you can do to see if you have leaky gut, and that would be to test to see what your zonulin levels are. So I just wanted to mention that to you. Leaky gut, really does cause a lot of inflammation in the body. And so if you have it, please address your SIBO, and please do address, once you address your SIBO, often the leaky gut clears much more easily, much more easily. Let's see. I wanted to ask about fatigue and brain fog from SIBO. Since I can't cure it yet, is there any supplement or strategy you've seen to help improve mental clarity and energy to help function on a daily basis? I've heard of a lot of people getting help from charcoal to help absorb some of those cytokines, and some gentle binders like chlorella. I know that's one of Dr. Seebecker's favorites, but it can constipate some people. Rarely, but it does happen. So you want to keep that in mind and start slowly. Does having SIBO and or emo for years cause any additional health issues? I'm so glad you asked that. There are a lot of downstream ramifications long term. Rosacea, restless leg syndrome are some of the things that you can get when you have SIBO, but also liver implications. You just really want to clear it. Ferritin levels being off, because ferritin is the iron reserves in the body, and those overgrowing organisms love it like chocolate. I heard somebody say that the other day, and I thought that is a clever way of getting the point across. And B12 levels or B vitamin levels can often be irregular. I don't have the answer to, do you see a lot of people getting SIBO after taking metformin? And maybe we can ask one of the doctors when they come on. Insurance companies and SIBO, because I'm in the Facebook group with the 30,000 people of all over the country, all over the world, in different insurance levels and Medicare and all of that, it just varies. And do I think having those codes help, which is why I took the time to mention them. I do think that that is a positive step in the right direction. And coming in hot, hello. Hi, Dr. Ivanina. How are
Hey,
you?
Siobhan, it's so
Hi.
good. It's so good to see you.
It's
I was
good to
for a
see
second,
you
I was
too.
like, wait, is this good? Are you
You're
like talking?
good. You're good. You're good. We
Okay,
love
good.
having you here. Thank
Thank
you
you
so
so much
much for
for having
joining.
me.
Happy SIBO Awareness Day, my friend.
Indeed. Changes lives, right? That
That's
that
right.
diagnosis, my goodness.
That's right. So, Dr. Ivanina, be sure
Yes,
to find her on social media. You have a really strong Instagram presence, so I love that. Thank you so much for all of that.
of
And
course.
just speaking of social, someone's asking about what's the name of my Facebook group. It's SIBO SOS. I think it's like virtual summit or community. Look for the SIBO SOS. And SOS has come to mean save ourselves, in conjunction with working with highly skilled professionals. So it's great to have you. I know Dr. Razai is going to be joining as well any second now. And we are going to get going with your segment. Very, very
Terrific.
glad to have you here. Okay. All right. I want to make sure we're actually doing really well on timing. And can I just pop a couple questions your way as we get ready for your official segment with Dr. Ali Razai?
Let's do it.
Okay. Well, first of all, let me give you the proper intro there. And that you are the GI and founder of the Center of Integrative Gut Health. You are quadruple board certified integrative gastroenterologist specializing in root cause diagnostics. That is amazing. Thank you for your commitment to education and helping so many people. That's fantastic. That was very
Thanks,
cool.
Siobhan.
Yeah.
It's triple boarded just to
Okay.
little
Somebody said quadruple. We'll take it. Oh, just triple. Just triple. That's amazing. Well, congratulations on that, and thank you for all of your help. Um,
Thank you.
do you see people who have been on metformin being impacted with SIBO disproportionately?
People who are on metformin.
Yeah.
I don't think so. I honestly have not seen a lot of people on metformin anymore since the rise of GLP-1s. I'll have
Yep.
to say, metformin, of course, has been, on the market for a long time, and people use it for, insulin resistance from PCOS to, of course, diabetes, types 1s and 2s. And I think it's an interesting connection to make because I think you wonder if it's due to the actual like medicine versus the condition that the patient
Right.
has, right, Siobhan? So I think like
Yeah.
we understand that people, if they're taking it for PCOS has been linked to dysbiosis. And so the question is that a dysbiosis, that could be SIBO? And the same thing with we certainly know type 1 diabetes for sure as an autoimmune disease. And especially since it's connected with exocrine pancreatic insufficiency, we know that that's associated with SIBO. So I think, I don't think I've seen any evidence that the compound itself
Mhm.
causes SIBO. I
Okay.
think there's a question about the condition it's treating. And also we do know decreases B12. And then a lot of people wonder, okay, is the B12 from metformin or SIBO or what? But yeah,
Exactly, which came first. Now, someone is saying that they heard their doctor saying that SIBO has exploded after COVID. Do you see that in your practice?
absolutely. Absolutely. I think that there are studies published from China after first wave COVID that showed, again, like really early on, we knew there was dysbiosis. We knew that there were receptors for COVID in the gut. We knew that the gut was playing a huge role. A lot of people have, gut symptoms. Now, of course, not every type of COVID has had the same impact, as we go through different, strains. I think it's been, variable, but
Yeah.
there's no question. I think that the dysmotility that happens with post-COVID, we know that there's been an uptick in gastroparesis, in POTS, in MCAS, and SIBO is something that, of course, is so common with all of these conditions. So yes, I for sure, I definitely agree, Siobhan.
Okay, and what about if someone is underweight? Can they do the elemental diet?
That's a good question. So I think that the great thing about Mbiota and the research around,
Yes.
hey,
Hey, representing. Yeah.
the research around it is that it's complete nutrition. And I think that in certain situations where patients are perhaps malnutritioned, they're malabsorbing from their SIBO, from their Crohn's, from all the different primary etiologies that that can cause so much malnutrition. Again, with the right team on board, with the right nutritionist and practitioners on board, Siobhan, I think that, yeah, absolutely, it can be done. You just have to be really careful, right? You have to understand Ambiota, each packet's 300 calories. You have to
Right.
understand how many calories a patient, is going to require. So I find a lot of patients, I actually use Ambiota even as like a supplement for gaining weight.
Yeah, I've seen that a lot too. Hi, Dr. Razai. Hi, you're muted, so we want to just bring you in hot on that mic. How you doing?
Hi, are we
Hi.
live or not yet?
You are live, sir. You are
All
so
right.
live. So
Hey.
live. I know we're a little bit early, but it's so great to have you here. And I know you're coming in directly from Cedars-Sinai in Los Angeles. So thank you very, very much for taking the time out of your day, too. And Dr. Ali Razai, gastroenterologist and medical director of GI Motility. He is a leading voice in GI motility research with over, count it, 300 publications. His work has transformed how we diagnose and manage SIBO. It's good to see you.
Great to see you guys.
Thank
Good
you.
to
See
see
you,
you.
Elena. It's been a
You too.
while.
What
Yeah.
Not
a,
not a while actually. We just had like
We
the
talk a
podcast
lot.
like 3 weeks
did we just
ago.
do
But
that?
anyways.
Well, that is a dream team right there. And I know you're going to be talking about the long-term treatments and maintenance, I should say, for SIBO and IBS. Now, do you all have a presentation, or I'm asking you questions?
We have an outline, Siobhan. We were going to
Okay,
start out. I was going to kind of give a little overview. Then
okay,
Dr. Razai was going to go through the best studied approaches, antibiotics, elemental diet, and I was going
great,
to go through the lesser known natural
great.
treatments, how to
Okay,
approach that. And
just want to
then
confirm that.
we're open to questions.
Okay, go ahead. I'm going to hide myself while you two geniuses download for us, and then I will see you on the other side of your presentation. Thank you so much.
You're so kind. Well, thank you again so much for having us. I am so excited to be a part of this event and raising awareness about SIBO, as I have seen how the diagnosis and treatment changes so many lives. And so together today with Dr. Rosé, we're going to be discussing treatment. And so just to kind of outline next steps, I'm going to talk about, the approach, evaluating root cause, and then the importance of a 3-phase approach. Then Dr. Rosé will discuss the best studied treatments, antibiotics, and elemental diet. And then finally, I'll discuss the less studied treatment options, natural treatments, herbal antimicrobials, microbiome manipulation, and how to safely approach them. So many people out there are struggling with a SIBO diagnosis, I think, because they just don't have the right testing or guidance and support to get them through the treatment correctly. And so to set yourself up for success treating SIBO, I really think it's key to identify and address your root cause and then approach treating SIBO with a multi-phase protocol that focuses on eradication, maintenance of motility, and then really repopulation and focusing on preventing recurrence. I'm not going to go too much into the different root causes, but wanted to just mention a couple things. First and foremost, you need to understand why you got SIBO. As I think many have probably heard, SIBO is due to something, and you really want to find and address your something if you want to ensure that your treatment is going to be successful and your overgrowth does not come back. So I've seen so many times patients who have treated SIBO successfully, they feel so great, but it's temporary and it recurs from days to months later. And so I really like to think about the root causes, thinking about different categories: structural, like adhesions; motility, post-infection with antivinculin issues and MMC issues; sometimes things like SIPO, chronic intestinal pseudoobstruction. Like to think about stomach acid. Does H. pylori or PPIs play a role? I like to think about medications, antibiotics and opiates; immunodeficiency, like IgA deficiency; organ-specific diseases, like we were just talking about before, type 1 diabetes, and how, of course, that affects the pancreas; and exocrine pancreatic insufficiency; hypothyroid, also recently published on, and its connection with SIBO; autoimmune diseases, IBD, especially Crohn's, right? Inflammatory bowel disease, so Crohn's, celiac, scleroderma. And then there's a bucket of other, and one of those is something like EDS. And I wanted to just talk about a couple points within the root causes. One of them is really Crohn's disease. Studies have shown that there are increased rates of SIBO in IBD patients, and especially more frequent in patients with Crohn's. I can't tell you how many patients with recurrent SIBO I have rescoped because perhaps the terminal ileum, the end of the small intestine, was not intubated on prior colonoscopy. And so when I rescope them, we find Crohn's disease. Literally, this happened yesterday. And so again, you need to understand that there's Crohn's. Why do they keep relapsing? You have to treat the Crohn's. I also want to emphasize EDS and the triad: EDS, MCAS, and POTS. We talked about this a little just as the intro, talking about post-COVID. I see so much SIBO with this triad. I feel like it should be renamed tetrad with SIBO. Because, you see a lot of visceroptosis in EDS. Also with MCAS, there's altered motility from the mast cell mediators that can affect MMC. And so again, like, these are conditions that are all so important to talk about, to look into, because they can really change the trajectory of someone's healing protocol. And then the final, I think important tidbit is, don't forget to look for conditions that happen at the same time as SIBO, like SIFO, small intestinal fungal overgrowth. And so there have been studies by gastroenterologists like Satish Rao that showed there have been patients where, SIFO is present in about 26% of people with unexplained GI symptoms, especially also prevalent in EDS. He did a study and it showed that actually 25% of the subjects with EDS Dr. Rao looked at had both SIBO and SIFO. Okay, so now that we've got that first section of root cause down, so someone's gotten tested, they found out they have SIBO and which of the three types of SIBO. They've identified their root cause and talked about could there be something else going on as well. Now you move into the multi-phase protocol. And so again, first phase, eradication. It's about choosing the correct treatment for the specific type of overgrowth that you have. And Dr. Rizé will speak about the best studied eradication methods, and I'll speak about the natural ones. But then phase 2 is maintenance and motility. That's about optimizing motility with prokinetics, assisting your migrating motor complex with things like meal spacing, making dietary changes such as low fermentation diet. And during that phase, many will also test for eradication to see the results of how phase 1 worked. And then finally, repopulation and relapse prevention. So with guidance, after you've tested and you've cured SIBO, you want to work to improve your gut health. So food, supplementation to strengthen your gut microbiome abundance, diversity, and of course, specific things to prevent relapse. Like if you're traveling to Mexico, you want to consider taking prophylaxis. If you have a history of post-infectious IBS with elevated antivinculin levels, you want to consider taking prucalopride long-term. So again, this approach is often missed for a lot of people. And I think if you keep it in mind, will really be an important part of healing your SIBO. So, okay, Dr. Rizé, take it away.
Yeah, that's fantastic. Yes. Thanks for that overview. And that's actually one of the main points. Yeah, I can talk about eradication like for a whole day, but that finding of the root cause is still should be on top of our minds as we do the eradication or maintenance of remission therapy, because at the end of the day, if you can find a root cause that can be addressed, then you can potentially cure the disease, and that's very clear. Example that Dr. Avanina said is that we do see it as well. Somebody with Crohn's disease. Well, no matter how many times you treat it, then the disease will come back.
Yeah.
So you just need to get rid of that inflammation in the small bowel that has led to this motility, that has led to dysbiosis, that is causing all these troubles. And now why Crohn's disease can cause a SIBO, and there is no shortage of studies showing that there is a big overlap between Crohn's disease and SIBO. That can be because of the small bowel not moving. Because think about it, small bowel is inflamed, it's not moving, and also very commonly Crohn's disease affects the terminal ileum, which is the last part of the small bowel where the small bowel connects to the colon and the ileocecal valve is there. Obviously, it affects the function of that valve. All those sort of points together we leads to a higher rate of SIBO. And when you get rid of the inflammation, granted that there is no stricturing, there's no fibrosis yet, then the patient responds really well to treatment of SIBO. And sometimes just an induction of remission is enough. Then
Mhm.
the patient does well as far as the inflammation in the small bowel is under control. So the point I'm making is that finding the underlying cause is very important in terms of management and also in terms of reassurance, because a lot of patients want to know, oh, like, why do I have this to begin with, right? And that is very key in management of patients for them knowing why this whole thing happened. So in terms of induction of remission, as Dr. Ivanino was saying, the grandfather of things is using antibiotics, right? Because remember, SIBO has been defined for many, many years. Originally, it was defined in patients with Billroth 2. Billroth 2 was a surgery that we used to do prior to antacids that would essentially juggle the bowel. Essentially, we have two lumens of the bowel. We would take somebody with gastric ulcer, take that ulcer apart, attach the remaining healthy stomach to the rest of the small bowel, and the other part was just having a blind loop and things would go through. People forget that what a miracle antacids were. We were doing Bill Roth too, like so many of them in 50s and 60s and 70s. And everybody thought it's okay, it's all stress and smoking and all that. And then obviously two big things happened. Number one, H. pylori was discovered as the cause of gastric ulcer, which again is microbiome related, something that was sort of denied and kind of frowned upon, that a bacteria can cause ulceration. And that kind of led to uh, a significant drop in the number of symptomatic gastric ulcers that we have. And secondly, the antacids, first H2 blockers, such as Pepcid, as you know, and then PPIs. And now we have even stronger medications like vonoprazan that are out there. That decreased the amount of gastric ulcers and subsequently the surgeries that we're having for them. But while we were doing those surgeries, the blind loop of the bowel was found to be full of bacteria. Why? Again, as Dr. Avenina said, so there's the movement if it gets affected. Now you have surgery, obviously now bacteria overgrows. So the treatment in that setting that was started, and this goes back more than half a century back, is was antibiotics. So, and in that setting, usually you have to use, by the way, systemic antibiotics, and that's actually a good parallel there. People with Roux-en-Y surgery and bypass surgeries, even for obesity, if they have SIBO, it's preferable to treat them with systemic antibiotics rather than non-absorbable antibiotics such as rifaximin, because rifaximin goes through the lumen but does not go through uh, the blind loop. And the same goes actually for treatment of SIBO, as Dr. Ivanini was saying. In that setting, also I use systemic antifungals because if I give nystatin, for example, this goes through, well, doesn't go through the 70 centimeter, which is about 2 feet of blind loop. So, antibiotics, which ones do we use usually in the setting of SIBO? There are multiple studies going back to 80s that people tried to see what is the most effective antibiotic. People have tried metronidazole. Flagyl is the brand name that we commonly use. People have tried amoxicillin. People have tried neomycin. People have tried ciprofloxacin. One point about ciprofloxacin is that we don't use it first line anymore, and that's because of the black box that we have with fluoroquinolones, which is the umbrella term for medications such as ciprofloxacin or levofloxacin that can affect the joints. Right. So because of that, we avoid that. Having said that, there's still a very commonly used antibiotics, but again, in the setting of SIBO that we know, they may need multiple rounds of antibiotics. That's not what we reach for on first hand. Another antibiotic that I use is doxycycline, good old doxycycline, although there aren't many studies on it. It's well tolerated and it's generic that we use. The issue is that some people get pill esophagitis with it, meaning that they get inflammation of the esophagus, especially when the capsule is not passing through. So make sure that if you take doxycycline, you drink good amount of water after it. Don't lay down for a good half an hour after taking doxycycline. And the poster child of the antibiotics used in the setting of induction of remission to treat SIBO is rifaximin. Rifaximin is a poorly absorbable antibiotic. So what do I mean by poorly absorbable? 99.6% of the of rifaximin doesn't get absorbed. It just goes through your gut and we just literally poop it out. And because of that, it has very minimal systemic side effects as opposed to, or systemic effects as well, as opposed to other antibiotics. And that's why we like rifaximin in that setting. Obviously, one issue with rifaximin, at least in North America, is the cost. Um, and that's because it's still on a patent. And that's something that will hopefully resolve in a couple of years when it goes off patent and rifaximin will become generic. So I guess that's pretty good news for a lot of us patients and providers because it's not it's rather expensive to get it in the US. So, and the dose that we usually use is 550 milligram 3 times daily for 10 to 14 days. 14 days is more common because that's the dose that is also approved for IBS diarrhea in the US. But studies done with 10 days have been successfully eradicated. And in fact, the original dosing for IBS diarrhea came from the Stefano study in Italy that they tried 400, 800, 1200, 1600, and 2000 milligram of rifaximin per day. And they saw that 1600 and above is effective. And actually, that's where 550 milligram 3 times daily dosing of rifaximin comes from. That study with the Stefano that showed 1600 milligram per day is effective for eradication of SIBO. So that's a kind of like overview of the antibiotics that we use in the setting of small intestinal bacterial growth. Now, if you want to talk about SIBO, so that's also we use nystatin. Again, the protocol that we use I follow what Dr. Satish Rao recommended in this setting, that I tried 21 days of treatment. Now, that can be systemic antifungals such as fluconazole, or it can be nystatin, which is poorly absorbable, almost unabsorbable antifungal. It's the same compound that we use for thrush in infants. So it's a safe medication. It comes in liquid form and also tablet form. Just remember the liquid form has saccharin in it. That's why it's kind of feels very sweet. But interesting enough, if you go back, saccharin is actually has a little bit of an antifungal effects to begin with. So that's why I think this compound start like going back to 70s had saccharin in it. So that's kind of the main induction of a remission sort of modality that we use. Now, some people can't take antibiotics. Some people have had allergies to it. Some people are intolerant to them. And some people prefer something that does not involve antibiotics, considering whatever reason behind it, whether intolerance, allergies, a drug interaction. And that's where we use elemental diet in that setting. So elemental diet, obviously, we can go very in depth about the clinical trials that have been done, but that's one modality that we can use. I kind of like talked way too much to like back to back, but I just wanted to see what Dr. Ivanina has to add before I go into the elemental diet part.
You know, I always learn something from you every time we speak, and so really fascinating to hear about the history, kind of an evolution of SIBO. And yeah, that other antibiotics are also used, and but of course have all these have potential side effects. And just curious, just again, like breaking it down into hydrogen, H2S, and methane, right? As far as antibiotics go, you know, I think there you can just talk if you don't mind, like about each category, and then like something like doxy, like where would you place that as as far as like the three different categories?
Yes, so when we do the breath testing, so like it can come back as hydrogen, hydrosulfide, or methane. In the setting of hydrogen, the antibiotics that I use, I reach for rifaximin first. And if that is something for whatever reason, whether it caused issues or patient has had bad reaction to it or no response to it, then I reach for other antibiotics. And so very rapidly, doxycycline, and I have to admit, that's anecdotal for me, has become like the second line for me that I use. Because it's twice daily, 10 days, and patient tolerate, it's generic, and as long as they drink water, that helps them. Yeah, other options, amoxicillin, but the problem is the amoxicillin patients get diarrhea. They don't like it. It's like it gives you cramps. And that's having said that, again, that's another accessible sort of antibiotic that we use. Um, when there is methane, obviously now the issue becomes that methane producing microbes are archaea. And archaea versus bacteria, these are completely different living organisms. In fact, actually, the domains of life, I don't know how much you remember, guys. So it's life, and then there are three domains of life. One is archaea, which were the first guys showed up on our planet, and they produce methane, some of them. And the only source of methane, pretty much, and on our planet outside of like volcanoes and chemical reactions is are these guys. And funny enough, this methane production kind of were forgotten in the rest of the domains that showed up later on, which are bacteria and then eukarya. And eukarya is huge. Now that includes fungi, that includes the animals, insects, us, everything, right? So, and remember, we are all three. So essentially, we're eukarya as a self, and then inside our body are the bacteria and archaea inside of us, so fungi and everything. So we're a combination of all that are just hanging out there. So the cell wall of archaea are different from the cell wall of bacteria. Um, and throughout the history, bacteria have been the bad guys in terms of killing us and being able to affect us dramatically. So that's why the majority of the antibiotics that have been developed in modern history affect the cell wall of the bacteria. But the problem now is that archaea have a different cell wall. So, and these antibiotics that work on the bacteria, well, can't affect these guys, right? Except for a few antibiotics such as metronidazole or neomycin that are effective against archaea. And that's actually very key when we want to suppress the amount of methane production. So you have to use a specific antibiotics to suppress methane productions in those guys, and also like suppress their growth. Now, on top of it, methanogens, i.e., methane-producing microbes, they need hydrogen to produce methane. By the way, that's not something that only happens in our body. It happens anywhere. When you go to a quagmire, when you go to a whatever mine, that methane that has been produced by a archaea has been using hydrogen produced by a bacteria close by. And these are called centrals. They just live together. They just hang out, right? And so if you suppress hydrogen production by the regular hydrogen related antibiotics, so obviously you decrease methane production too. So that's why we use combination therapy in these patients. For example, the classic one is rifaximin neomycin that we use. Neomycin is poorly absorbable. And so that's why we like it. Having said that, there are case reports of it affecting sort of like hearing. I personally, over the last 12 years that have been prescribing it, haven't seen that. And also in the prospective trials, the people haven't seen that. But again, that's a possibility. The other option is rifaximin plus metronidazole. Now, if rifaximin is not available, options that I have used is ciprofloxacin plus metronidazole. Again, I'm not a big lover of I'm not in love with the ciprofloxacin, so I try to avoid it. And also, I have tried augmentin too, that has worked relatively well in patients. But also remember, if you're out of options for hitting archaea, so you can use neomycin, patient has a reaction to it. Metronidazole, and sometimes some people get really bad nausea with it, they don't like it. So in that scenario, you can use rifaximin alone, even though it is not as effective. But that is something that has been shown up to 43% of the times it can suppress and improve things. So that's one thing to remember, that you're not out of luck in that scenario.
Mhm.
And the last part in the setting of the sulfite producing a bacteria, obviously we're learning more and more about these. They're a giant group of bacteria, so it's not that every single one of them is a bad guy. But traditionally, one thing that we know that can suppress sulfur production is bismuth. Bismuth is actually an element, but actually behaves as an antibacterial as well. And that's why, for example, we use it in treatment of even H. pylori,
Mhm.
that we use it in that scenario as well. And that's why for example, Pepto-Bismol is a very effective treatment for traveler's diarrhea and even prevention of traveler's diarrhea because it has an antibacterial effect. In fact, actually, there was a large prospective trial that showed, yes, it decreases traveler's diarrhea if you try the good old Pepto-Bismol. But the active ingredient of Pepto-Bismol is the bismuth.
Mhm.
By the way, when you take bismuth, a lot of patients send a message with panic. You can get a very black discoloration on your tongue, and people are like, "Oh my God, what happened? Is that the like mold? What is that?" That's just bismuth. Don't freak out. And also, it changes the color of the stool. It gives you a very super dark kind of color, but it
Mhm.
doesn't become tarry. It's just super dark. So it's not blood. It's just the bismuth. So don't freak out when you take bismuth. So what I was saying is that if somebody has excessive amount of hydrogen sulfide and has diarrhea, I commonly use bismuth as an adjunct therapy as well. But I use rifaximin in that setting as well. That helps the patient. Um, Anything else I should cover?
No,
Mhm.
I had one kind of question before you move on to elemental, which I feel holds up a lot of people's decision to take antibiotics for their
Mhm.
SIBO, which is they've taken antibiotics before, they've caused gut issues, right? And
Mhm.
some of them actually were fine before they maybe took a couple courses of antibiotics for UTI, sinusitis, right? You name it. I was wondering if you can talk about rifaximin specifically, just because it is such a backbone of SIBO treatment for all
Mhm.
three types. Does it affect the good bacteria in your
All
gut?
right. Well, I mean, it's the first of all, microbiome field is constantly is dynamic as it's improving, and things
Yeah.
are now we have new techniques and everything. So what I'm gonna say is based on what we know now. Now, what happens in future, I don't know. So bottom line, what's interesting about rifaximin is that it's quite effective in the small bowel,
Hmm.
but then it crystallizes in the colon and it doesn't affect the colon as much. That's
Hmm.
actually interesting. It's segue here because rifaximin has also been used in the setting of diverticulitis, which is a colonic disease, right? Think about it. But that again shows you that modulation of small bowel microbiome can treat disorders of the colon related to microbiome. And the classic example of that, trying oral fecal transplantation in patients with C. diff. So it's kind of naive to think that that kind of like poop pill, as we call it, would get all the way to the end of the colon. It's not. It's essentially
Right.
modifying the small bowel microbiome, and that actually
Mhm.
leads to eradication of C. diff. So it's kind of like interesting concept. So because of that, the effect on the gut microbiome in the colon, which is the big bulk of this the our microbiome, has been minimal, and it has no antifungal effect, and it has no antiviral effect, no antibacteriophage effect, and all that. So it doesn't affect that.
Mhm.
So Mark did a study that they looked at the stool before and after
Mhm.
rifaximin, and this was part of Target 3 trial, which was the FDA-approved sort of clinical trial to assess rifaximin in the setting of IBS diarrhea. But some of them underwent the breath testing, and it turned out two-thirds of IBS diarrhea patients have SIBO, not surprisingly. But they also underwent stool testing before and after rifaximin, and they saw very minimal change in the amount of gut microbiome. Also, we need to look at other disorders that we use rifaximin in, right? So rifaximin is also approved for hepatic encephalopathy. Just to
Mhm.
explain what hepatic encephalopathy is, so when we have a very sick liver, liver, one of its job is to get rid of toxins, right? We call it the first pass. So whatever you digest and bacteria produces and all that, it goes through the bloodstream, goes through the liver, and liver filters that and takes the bad guy out, detoxifies it, and sends the blood into the systemic blood flow. Now, in people with cirrhosis, when liver is not functioning, so that first pass is gone, some bacteria in the gut can grow and produce compounds that lead to encephalopathy, which is starts with the sleep cycle abnormalities all the way to tremors, and also the end stage can be even like coma. Now, when you give these people antibiotics, they get better
Mhm.
dramatically. And that's actually one of the best examples of brain gut axis, if you think about it, that essentially gut is producing things that completely affects the cognition. So
Yeah.
that medication has been approved by FDA since 2015, if I'm not mistaken, for hepatic encephalopathy. And we have patients that go on this medication twice daily for more than a decade that we have these patients. And in fact,
Mhm.
actually, I think it was 2012. So more than 10 years they have been on it, and they're doing fine, right?
Yeah.
And I don't
Yeah.
think we have any more long-term data on any other antibiotic
Mhm.
that tells you that okay, these guys are doing fine. And in fact, data points towards the fact that people on long-term rifaximin has with hepatic encephalopathy have less um, hospitalization, have
Mm.
less sort of a worsening of their symptoms, and they're doing better. So
Yeah.
again, that's again doesn't guarantee that it's perfectly preserving our gut microbiome, but that's that's as good as it gets, kind of like data.
Yeah.
Now, there was a couple of basic science paper recently came out, one of them in Nature that came out, that suggests that long-term use can potentially affect the some of the resistant bacteria
Mm.
in the colon, which that data is out there, and now there's a study actually ongoing in Taiwan. Maybe it's published already, but I was just reviewing it, and that kind of like confirms it. That it was like, okay, we don't see any clinical endpoints that are worsening with this, but hey, they're
Mhm.
popping up, and
Yeah.
that's not um, that's something that's it's on people's radar,
Mhm.
and obviously as our techniques to assess um, gut microbiome is advancing. And also, these days, we don't go and grow the bacteria and see if they're resistant to bacteria by putting pellets on it right now, right? We don't do that anymore. What we
Hmm.
do is that we get those bacteria and we look for the resistant genes inside of them, right?
Yeah.
So
Yeah.
it's that has revolutionized things. So now instead of me going and growing things and say that, okay, does it work, does it not work, and all that, that has advanced that field dramatically, and we will hear about that more and more. And I wouldn't be surprised that there is no signal there. There should be something, but how much that affects us clinically, we don't know. Having
Mhm.
said that, using it intermittently, we have done that for many, many, many years, and I haven't had sort of like issues with it. In fact,
Yeah.
remember, one of the off-label uses of rifaximin, in fact, were commonly used uh, uh, in Europe, is for in the setting of C. diff.
Hmm.
Um,
Hmm.
that we use rifaximin to treat C. diff, which we know is a disease that comes most of the times because of somebody taking antibiotics. So we treat it with
Sure.
rifaximin. So again, small microbiome modulation leads to improvement of some colonic
Yeah.
microbiome disease, which is a fascinating concept there. Yeah.
So much information. I love it. I love it. Do you want to jump in to
Elemental diet, right? Let's do it.
elemental? Yeah.
Yes, so that's a big topic, and I think it's getting hotter and hotter, and I'm happy that it's getting hotter because obviously it's if we can treat things through diet, that's a very clean way of doing things.
Yeah.
So just to step back, elemental diet, everything that we eat, it has protein, carbohydrate, or fat, and also on top of it, we need the elements and also vitamins to survive. That's pretty much all we need.
Mhm.
Roughly 70 ingredients, and with that, we can survive. Um, so all of these need to go to your gut and get digested. Carbohydrates, very complex. They need to get digested and we absorb it. And the final product is usually monosaccharides, like glucose and fructose, and they get absorbed. Lipids need to be broken down to fatty acids, and also proteins need to be broken down to amino acids, right? So this process actually it's very costly, and one of the reasons that the humans, evolved to go all corners of the world is that we figured out how to do it as opposed to a lot of other animals and living organisms, because we can survive on different sources of food. Having said that, it costs us. It's about 20% of our daily calorie expenditure is used to break these food down. So it's a lot of like energy. Also, it's like there are hundreds of steps for these foods to be broken down to those pieces. And, those steps can go wrong. There's a lot of enzymes that are involved, genetic mutations, or any disorders that can affect these enzymes that we can't absorb it. So elemental diets were sort of evolved and going back to even 70s at that point to have all these food as pre-digested, all those elements, so we can take it.
Mhm.
Some trivia over there is that one of the first reasons that this was developed was that one of the biggest problems you probably heard on the Artemis recently. Pooping in space is not fun. So the bathrooms and space stations are a little bit nasty, and also they're just vacuum. They just put it in, and they just suck in everything as out. So considering all those challenges that in 60s and 70s astronauts had, they were like, okay, can you give us some sort of food that has no residue? So essentially, I don't poop, so I just absorb everything. So they tried this at the beginning there, but the problem is that even when we don't eat, there is constant flow of
Mhm.
food through our gut by sloughing our gut. Remember, our gut sort of renews every 5 days.
Yeah.
and cells just fall in, and there's
Mhm.
bowel secretions and all that. So even if you are not eating anything, you will continue to poop a little bit.
Mhm.
So that problem can't be fully solved in space. So you have to sit on those vacuum toilets, which, as you heard, broke down for the first few days in Artemis. I don't know what they did, but anyhow, I don't want to know. So at the same time, they figured out, wow, they have multiple sort of health benefits. And now
Mhm.
these health benefits are for multiple sort of reasons. Number one is that they have amino acids instead of proteins. Remember,
Mhm.
allergens are proteins or peptides. If you have amino acids, they can't be allergens, right? So our body doesn't react to it. So by definition, they're allergen free.
Mhm.
Obviously, they give us a little bit of a reset and rest in the setting of our eosinophils and mast cells, kind of like in terms of exposure to food allergens. So that's number one. Number two is that they are very low fat. So that's why chronic pancreatitis patients that are very sensitive in digestion of fat are helped. They get absorbed at the beginning of the small bowel, and the rest of the gut kind of like doesn't see food, similar to a pseudo fasting state, meaning
Mhm.
that you're eating, but the rest of the gut is not seeing food. So you get some of the benefits of fasting, intermittent fasting, with elemental diet. And they're anti-inflammatory, and also they don't have food additives, right? So there is no questions. All the sweeteners, food colorings, microplastics, and all that, they're harming us. But the thing is that we can't avoid them; they're everywhere, right?
Yeah.
So they don't do that. So obviously they don't exist in the elemental diet, so you're not exposed to it while you're taking it. So, and
Mhm.
many other reasons. The modulation of microbiome is being one of the main ones. So it turned out that they're effective in Crohn's disease, not surprisingly,
Mhm.
eosinophilic
Mhm.
esophagitis, not surprisingly, eosinophilic gastrointestinal disorders, and short bowel syndrome, chronic pancreatitis, and also SIBO and EMO. The
Mhm.
original study was a retrospective study, which was done with the old school Vivonex Plus, which is made by Nestle. But the issue with that is that they taste foul. The
Yeah.
amino
Oh.
acids actually they they're very sulfury. It's almost like a rotten egg when you have it.
Mhm.
And I've tried it. So that was a positive trial, but the thing is that many people can't do it.
Mhm.
Up to half of my patients after the first sip, I was like, okay, man, forget it. I'm out.
Yeah. Terrible.
But now with the advancement of flavor masking and food engineering, now, for example, Embiota has figured out how you mix all these together and with in what way and what sort of concentration that makes it palatable. And that's when we did the clinical trial a couple of years ago where we gave it to 30 subjects and participants with EMO and SIBO. And for 1 week, they were just at the baseline. 2 weeks, we gave them exclusive elemental diet. They were allowed to have as much water as they want, as much that they could have black coffee. And also, they were allowed to take as much sort of elemental diet as they want. And then 2 weeks of follow-up, they reintroduced regular diet. The key was that 100% of these patients were able to tolerate the diet, which was a big advancement as opposed to roughly 60% of other clinical trials because it was palatable. So that's one big advancement and showing that palatability increases tolerance.
Of course.
And also, we saw that 73% of the patients at the breath test normalized, and also 83% of the patients had symptomatic control.
Mhm.
One interesting thing and that's the difference with elemental diet and antibiotics. What we saw with the breath testing is that when we do breath testing, we see a rise in uh, like hydrogen in the SIBO that goes up before 90 minutes. But in normal subjects, the rise happens after 90 minutes, which is the normal colonic fermentation. When you use antibiotics, you even lose, especially systemic antibiotics, you lose the colonic peak as well, because you just decrease the amount of bacterial load even in the colon. But with the elemental diet, you don't see that. Actually, this early rise kind of shifts all the way to the colon. So you switch an abnormal small intestinal fermentation pattern with a normal colonic fermentation pattern, which is very key in the setting of elemental diet. So that's one thing that we saw and that was very impressive. But for the methane, it just kind of like suppressed it. And we kind of proved that with with using the PCR of the Methanobrevibacter smithia, which is the most accurate way of saying how much Methanobrevibacter smithia, which is the methane producing guy in the colon. And we showed that. Also, reassuringly, we saw that the core microbiome, which is the fungal component of the colon, was not affected. This is Saccharomyces cerevisiae. You probably have seen some of the probiotics with that. And also, Candida actually dropped by twofold. Because one of the worries was that because one of the worry that we have with antibiotics is fungal bloom. Because, in real life, fungi and bacteria are constantly fighting. Now, you give antibiotics, well, fungi is like, thanks, you killed my competitor. Now I'm just shooting up. I'm blooming, right? But with the elemental diet, the mechanism of action is different. Now you have the normal flora starting to grow back, and now that starts to keep the bad bacteria away, also keeps the fungi in check too. So it doesn't allow them to go nuts. So, so that's one interesting thing that we saw. And also we saw sort of other benefits as well with it. So that was a very sort of a positive point. Did I mess up
Dr.
timing?
Razai, no, you're
She
fine. You're
she
fine.
won.
I have a question. Wasn't there like 100% remission? Like, isn't there 100% statistic floating around?
Yeah,
Right.
so
Could you
for
just
the
repeat that for
SIBO
me? Because
patient,
that's my
so
favorite part.
so there were like different subgroups of patients.
Yeah.
Patients with SIBO alone, people with no methane, only hydrogen, their actually irradiation rate was 100%. Right. But obviously this is limited
Amazing.
number. So
He doesn't want
obviously
to
if you do
overpromise
it on
everybody. He doesn't
1,000
want to
patients, it's not going to be
overpromise.
100%.
Yes, I understand.
Yeah.
We
Yeah.
understand.
So yes,
Yeah.
correct, correct.
But I just like, for those of you who think that like there's no hope, right? That you've tried everything, that it's
Hmm.
no one ever cures it. Because we come to these SIBO awareness days and different events and master classes, and we're just talking to people who are still suffering with it. So it can be, in many, many cases, eradicated. And then you do your prokinetic to help,
Hmm.
with long-term
Yeah.
relapse prevention, etc. Did you, either one of you, wanted to touch on anything else before we got to a massive amount of
Oh
Q&A?
gosh.
Oh my God. No, I think Dr. Avenino wanted to talk about the other options that we have
Yes,
available
yes,
for
the
treatment.
herbals
Yeah.
and etc.
Yeah.
Yes.
Sure, I can breeze through. There's very little data. There's very little science behind it, like there
Yeah.
is behind, right, the kind of history of SIBO and history of elemental diet, right, which, like you said, has been around, for some time. And I did that taste test, and I forget if it was DDW or ACG. Oh my gosh, that Vivinex was so bad.
Yeah.
But yeah, I wanted to talk about the lesser known, lesser studied way to approach eradication and really how to do it safely, because I see so many patients that will come to me who have been on some of these supplement protocols for months, and they've been malabsorbing and they've been losing weight. And it can be done, in a way where I think patients can really struggle, or I think that they, if with the right practitioner, it can be done in a way that is actually very safe and can be very helpful. And so I have a lot of patients, come in and ask about these like natural approaches, which I think can be, again, a possibility for some patients. And I think that the key is you have a specialist on board, make sure, the specialist can have access to testing, right? Of course, we need to have like normal liver function. We know that, herbal combinations can hepatotoxic. So before you embark on these, on these protocols, you want to ensure good liver function. You might want to recheck it, while you're on it, depending on what, issues arise. And of course, also then like when to quit and move on to another approach, because it's also not for everybody. And I just wanted to talk about, there are really two papers, and that's really it, that have looked at herbs in SIBO. One is the famous one I'm sure everyone here has heard of, about the equivalence of rifaximin to herbs, in treating SIBO. And the other one is actually the oral botanical supplement with, and also looking how it treats SIBO and facial redness, interestingly. And that one looks at biocidin. So the first one is the one from Hopkins, looking at Candibactin ARBR. They also looked at dysbiocidin FC-cytal. It's about 100 patients. And interestingly, actually, when you were talking about just before the dosing of antibiotics, right, they interestingly dosed their antibiotic arm at 1,200 milligrams daily. So again, not really the dose that we use typically right now, right? 550 TID 3 times a day. So interestingly, they had their two arms. They had rifaximin 1,200 daily, and then they had herbal therapy for 4 weeks, right? So again, Candibactin ARBR. AR is mostly things like oregano oil, thyme oil, sage leaf, and then BR is mostly berberine and also other things like Oregon grape and coptis. And then the spy side, again, another mix: wormwood dill, FC-cytal, thyme, olive leaf, tarragon horsetail, and some other things. And so out of these patients, again, not a lot of patients in the end, it was 37 who received herbal therapy. 46% had a negative follow-up breath test compared to 34% of rifaximin users. Not statistically significant, p-value was 0.24. But, I think that there was, again, a signal that it could be used. It can help some people, and it was found to be safe. There's actually only one case. The only side effect reported was one case of diarrhea in the herbal therapy arm. And so again, I think that, you look at these studies and you can work with a practitioner to have an approach that is safe. Obviously, again, seeing that there is at least some kind of study done, especially to look at the safety and the duration and the dosing. I like personally the Candibactin protocol because of the berberine. There's actually a DDW abstract looking also, I think it was a non-inferior study to rifaximin, and it was just the interim analysis that they looked at. Also, again, like showing that berberine can actually be a terrific microbiome modulator, both to decrease overgrowth and actually also to increase some of the beneficial microbes. The other study, just quickly, was another small study. Again, it was 19 out of 33 adults that were screened, found to have SIBO. They were given 10 weeks of a biocidin liquid and GI detox. So the biocidin, actually kind of similar ingredients, right? You've got the oregano oil. They also have things like black walnut, tea tree oil. And the GI detox, interestingly, is what we refer to as a binder. So it's got these clays, activated charcoal, also something we use, I'll also suggest with bismuth as, sometimes helpful when you're traveling. So together, if participants were found to be non-responsive after the 10 weeks, then they would add even one more supplement, which is called Oliverex. That one is mostly olive leaf. There's some other uva ursi, milk thistle, again, like a lot of different herbs together. And what they found in the end was that this was actually a pretty decent approach for hydrogen and hydrogen sulfide dominant SIBO. So with hydrogen, 42% eradication, negative breath test, and hydrogen sulfide, actually 66%. One person dropped out, I think, because of headaches. And again, not for emo. They didn't have a lot of emo participants, and so there's not a lot of good emo data. But again, for hydrogen sulfide, not bad. And then I also did want to really touch upon microbiome manipulation, right? So there's this idea of the crowding out method, prebiotics, probiotics, and then of course, microbiome manipulation like fecal transplant. So very few studies looking at Saccharomyces boulardii. But again, like Dr. Reze said, like, right, in patients who usually can't take the antibiotics, right? So these are sick patients, cirrhotic patients, right? Well, again, maybe actually rifaximin may benefit them. But again, some of these patients really sick, cirrhotic, scleroderma, and they found, so Saccharomyces was one, VSL3, another blend, had significant reduction in SIBO, and even VSL improved transit time. So I just wanted to kind of paint a picture that there are some studies about natural options. Another one is looking at sun fiber, PHGG. Another one is fecal transplant. I think, is it just one study, Dr. Jose, on
Yeah,
fecal transplant? I
yeah,
think they
yeah,
did with
yeah,
the capsules,
yeah, yeah.
SIBO. I mean, and the gut microbiome diversity of the FMT group had a great increase, of course. GI symptoms significantly improved in SIBO after the FMT. So
Mhm,
I think that, just to understand, there's not one approach to healing SIBO. I think a lot of people, have options, but
mhm,
just to do them safely, to have like
Yeah.
a good practitioner they can talk to, they can get tested with, and take that
mhm.
journey in a really safe, planned out way to get the best results.
Perfect.
So one point I wanted to ask though, so because anecdotally I've had success with it, and also you have a lot of experience with it, the fennel seed and magnesium, I definitely use that, and it's working really well with my patients. So I just wanted to understand how does it work and what does fennel seed do? Do we know, or how does it work?
Thank you so much for bringing that up. So, interestingly, so this is a product that I'm a part of creating. So it's a
Uh,
fennel seed magnesium oxide
uh,
um, product. And so this product really came in to be a little bit more of the support for the maintenance and motility phase. Now,
mm,
the interesting part is because fennel does have some antibacterial,
mm,
antifungal properties. There was a study from California, I think it was UCSD, where they even
mm,
looked at it in IBD and for helping intestinal permeability. And
mm,
so, again, these are small studies, because herbs don't have like a big pharma
mm,
background to support their use. But so what we did was we really looked at the ACG AGA guidelines for constipation, right?
mm,
Magnesium
mm,
oxide, safe. That's the one that,
mm,
they recommend as far as a magnesium type. And then the fennel seed has been described by, some of our gastroenterologists, like at the different conferences, like Anthony Lumbo from
mm,
Harvard, right? And he's written about using fennel seed. Similar
mm,
sometimes also to peppermint, has that relaxing quality to,
mm.
for spasm, and which can lead to ineffective motility and pain and so many things. And so this is, I would say this is definitely not an eradication, that combination. It's not what I would recommend for pure eradication, but I think it is a really great support for people on the
Right.
journey, for their motility support, and again, some candida effect and intestinal permeability support.
Well,
Oh,
fennel and
fantastic.
Ayurveda are certainly, that's an ancient approach for digestive support. You eat an Indian
Yes,
meal and afterwards you grab those little seeds afterwards to help with the bitter and all of that. That's amazing.
yes,
Okay,
yeah.
ladies and gents, we've got questions for you. So many questions. You ready?
Mm.
Do we need a Sadie break? Hold on. Hello, Sadie. Sadie's here.
Oh,
Hello, everybody. Okay, bye-bye.
so
Mwah.
sweet.
All right, just a little central nervous system reset. If someone with frequent SIBO relapses, any advice on what to do next or how to extend remission beyond 3 months?
How should we handle? You want to just go back and forth? Do you want to
Sure,
take the first one? It doesn't
sure.
matter.
Dr.
It,
Razai, take that one if you would.
oh yeah, yeah,
Yep,
I'll take that one because
we'll go back and forth.
Dr.
Yeah.
Ivanina covered that. So the pro-motility drugs are now our mainstay of a therapy for that situation. Obviously, we make sure that in terms of diet, we're modifying things that patients are not taking something that is super fermentable that is like causing the relapse. But usually, patients with multiple relapses of SIBO are very diligent about their diet. So we reach for pro-motility drugs. And these pro-motility drugs are medication that activate the housekeeping waves. Remember, during fasting, every roughly 2 hours, a wave comes in and tries to clean the small bowel from the residual bacteria and residual food, and it cleans it essentially. Just literally housekeeping every a few seconds, 11 times per minute to be exact. It just pushes things forward and milks the small bowel and pushes forward. And now these contractions are mediated by multiple receptors. One of them is motilin. And motilin receptors can be activated by erythromycin, for example, or azithromycin. So that's why you hear using low dose erythromycin or azithromycin. Also, serotonin receptors, especially 5-HT4, activation of that helps. So low dose, for example, prucalopride, we do use it. Now, activation of vagus nerve, that also helps that. I know the colleagues use like vagus nerve stimulators, or they can we do even use mestinon as a treatment, which increases the amount of acetylcholine, which is how vagus nerve works on the muscles in our gut. So those are some of the pro-motility drugs that we use. I know there are like multiple other ones, but those are the classic ones that we reach for in terms of pro-motility drugs. Now, do I have patients that unfortunately even pro-motility drugs don't make a dent in that situation? Yes, we do. That's a time that we go back again, reassess. Am I missing an underlying cause? Exactly what Dr. Ivanina said. Okay, what am I missing? Where is it? Is this something that is modifiable that we miss? So that's one important thing. And other things that we use, we try to avoid chronic antibiotics, obviously, at all costs. But again, rifaximin long term has good safety profile. And also, replacing one meal a day with elemental diet has been tried in patients with chronic pancreatitis in a large study in Japan,
Hmm.
more than 500 patients, 280 centers, and that was very effective. And they did that for actually a 12-week period. And so that's actually one trick. So that I sort of replace breakfast with elemental diet, and they can have their lunch and dinner, and to see how that if that kind of keeps things at bay. We're hopefully doing a clinical trial soon, addressing that to see how that affects the microbiome in healthy subjects. So those are the tricks that I use to address refractory or recurrent SIBO cases.
On top of that, can Embiota elemental diet be used while the intestine recovers from celiac damage?
So specifically, well, that there's an ongoing trial with that,
Okay, great.
yeah, in the past there are two studies that have been published. One with refractory celiac disorder that the elemental diet showed to be effective. The other one is refractory dermatitis herpetiforme associated with celiac, which is the skin rash associated with
Hmm.
celiac,
Okay.
which sometimes, interesting enough, doesn't respond to gluten-free diet. So there are
Hmm.
two small studies that lamictal has been effective in those patients. Now, can it help with the gut permeability issues that clearly exist in celiac? Theoretically, yes. I don't have any data to back it up. No.
Okay. All right. And Dr. Ivaneva, a question for you about Hashimoto's and hypothyroidism. Can you explain how those lead to SIBO?
Sure. So I think there was actually a study out of Cedars-Sinai that was published from I guess I think it was probably a joint endocrinology GI study, looking at hypothyroidism. So that's Hashimoto's, and looking at hypothyroidism, which, again, I think one of the biggest connections is the hypomotility, right? So when you first of all think about Hashimoto's hypothyroid versus hyperthyroid, right? People who have hypothyroid have sluggish motility, very much the opposite of hyperthyroid. And, I think that the things that have been looked at are changes in the microbiome and changes in intestinal permeability.
Mm.
So again, if you put them all together, and a lot of people have this condition for so long before they have before they actually get treated with replacement. And when they get treated, I believe the study showed, right? Then, again, these things resolve. Your motility gets better. Like, things will all improve. You just have to get the diagnosis and the right treatment. Again, it's a true root cause condition.
Perfect. Okay. And should you stay on a prokinetic while on the elemental diet?
So, yeah, I do this case by case, I have to
Okay.
admit, because elemental diet, some people get loose bowel movement. I mean, the majority of people get a loose bowel movements on it. So now you have promotility on board, obviously you can get diarrhea. So you have to, that's what you need to be careful about. Having said that, there is another subgroup of patients that stop having significant amount of bowel movements with it. All right. So in those cases, actually, I continue the promoted drugs. In people who get loose bowel movements to a point that it becomes a little bit annoying, obviously I stop it. So I do it case by case, at least in my
Okay.
practice.
And for Dr. Ivanina, if untreated, how long can SIBO last?
Oh gosh, if untreated. I
Untreated.
mean, I think that there's probably no end point. I
Mhm,
think that
Right.
once you develop that type of dysbiosis,
mhm,
people have daily symptoms. It's not like a,
Yeah.
one day have it, one day you don't. Like this becomes your microbiome until
Right.
you
mhm.
do something about
Beautiful.
it.
Yeah.
Perfect. Okay. And then it's our last question. Can you please mention, Dr. Razai, why cyanocobalamin, I don't know if I said that right, is used in Embiotta rather than methylcobalamin for B12?
Right. I mean, the whole concept of like whether we use methylated vitamin Bs
Yeah.
or vitamin Bs. So remember, in the setting of elemental diet, the way we absorb and the vitamins are a little bit different. So now we have like a direct exposure of vitamins and also the minerals to the gut. They're not like hiding in the middle of whatever like the sourdough that you're
Right.
having, right?
Right.
So what we have seen, at least in our patients, the and we measured the vitamin levels in the clinic, and we didn't see any sort of dip. If anything, they were all repleted with that, and that was the reason that we kept it as like a
I think
non-methylated
actually I'm just getting a notice from Maeve that they've updated the ingredients to use methylcobalamin. But see, so there you go.
Well, that was the clinical trial, I guess, and now we have methylated.
Okay. Okay.
Yes.
Okay, y'all, our time is up. I wanted to say thank you. Can we all put some love into the Q&A box and some hearts, etc. We're going to keep rolling on time here. Your genius is so appreciated, the both of you. Keep up the great work. Godspeed. And thank you very much. We are going to do a giveaway. So we'll wrap up and say, have a great day. And thank you so much for being part of this important event and all your great work.
All right. Thank you so much.
Thank you.
Thank
All
you.
right. We'll talk to you
Bye.
later. Bye bye.
Bye.
Bye bye. All right. If you would like to be part of the giveaway that we are doing, then we have, are you ready for this? This is a good one. They're all good. Hold on. Here it is. They're going to put up the poll, and it is Biome Botanicals. Is this a combination, you guys? And then a 2-week protocol of M Biota. Whoa, that is a great one. That is amazing. So they're going to put up the poll, and you have to enter in two separate giveaways. Okay, so this is Biome Botanicals, and this is one bottle of Go, which I believe is the phenyl magnesium product that Dr. Ivanina was talking about. And that, yes, it's Dr. Ivanina's brand, exactly. Biome Botanicals. I've seen that online. I really can't wait to try it myself. And if you want to be entered to have a shot at that giveaway, then go ahead and type that in. And then after that, we're going to do the poll for the 2 weeks of the Mbiota, which is fantastic. And then you'll be reached out to by the SIBOawareness.org group to let you know if you have won. So excellent. Okay, Biome Botanicals, that's going to be like sort of going once, going twice. And be sure to go and check out these folks, their websites. They've contributed so much of their time and energy to this special day. And I'm so glad that we're able to share some of this with you in terms of a giveaway for those of you who do, the one that's picked. And they have the way they're picking is there's something on like Google that you can throw everybody's name into the mix, and it sorts it kind of like a casino, only better, and it plucks a name out, and that's how they're choosing. So I just want you to be aware of that. And then we've got one more presentation. We're going to switch to the next. Okay, great, Megan. Thank you so much behind the scenes. Here comes hi, Stephanie. Here comes the 2 weeks to Mbiota. Hi, Aaron. Hi. So be sure to fill out the Q and the yes or no on the Mbiota giveaway right there. Fantastic. We got to give equal time, so it's going to take a second. Make sure you're getting in there, and hopefully on the phones it still works. We're not sure. Some people it did work and some people it did not. As SIBO Awareness Day continues 2026, we're going to be talking about maintenance and long-term support with Erin Judge and Stephanie Mendez and preventing relapse. I know a lot of you have questions about that. Diet and lifestyle strategies, flare management, and transitioning off of treatment, because that I get so many people asking us about what diet should we do, what table food should we do after an elemental diet. And one of the best suggestions I heard was just don't have a whole pizza. Like, just there's a baseline to start with. There's just like one little tidbit of advice you can have, like, we'll find out from you what your suggestions are. Okay, about how many more seconds now on the giveaway, and then we will be moving on. Okay, just a few more seconds there, so be sure to get in on that. And I think we're good. Okay. All right. Let me introduce our very special guests now. Thank you so much for being here on SIBO Awareness Day. We have Erin Judge, who is a registered dietitian, RDN, and founder of Gutivate. She's a specialist in medical nutrition therapy for IBS, SIBO, and functional GI disorders. And then Stephanie Mendez, RDN, and gut health specialist, co-author of the Spanish edition, thank you, of Mind Your Gut, clinical training across IBD, outpatient care, gut transplant and rehab, and inpatient GI. What a pleasure to have you both here.
For having me.
Yeah, thank you so much.
Thank you so much for spreading the word. Erin, I know you've got a big summit going on this month as well.
Yeah,
go ahead and give it the shameless plug, sister. Do it.
Celebrating all things IBS. So throwing SIBO in this week. We're actually doing SIBO next week. So lots to learn there, but a full month of free webinars for patients to get access to those out of the box IBS pieces of the puzzle. So we've covered dysautonomia, mast cells today. We're talking supplements, we're talking diet, pelvic floor dysfunction, all the fun things that impact many of our lives. So it's completely free, still going on, and you can still join if you want to.
Great, great. And Stephanie, how can we find the book you've written in Spanish or contributed to?
So I think you guys have incorrect data, but that's not accurate. I did not co-write a book.
What have you been up to, Stephanie?
I'm the GI dietitian at Cedars-Sinai Motility Center. So I work with Dr. Rizai and Dr. Pimentel and the rest of the team here.
Okay. Thank you very much. Okay.
Sure.
So you specialize in a low fermentation diet as well. Okay. And we're going to give you some questions and we will take it from there. Okay. So here we go. Okay. What are your core diet and lifestyle recommendations for someone who has a SIBO diagnosis? Stephanie, we're going to let you go first.
Sure. I'm going to do a high-level overview of this because I think some of the answers we'll touch on a lot throughout the rest of the time today. But I have like three main areas that I recommend patients focus on when they have a SIBO diagnosis. So the first would be to support motility. That could be done in a number of ways, but one of the ways could be to space meals apart, whether that's from 3 to 5 hours, and I'll go into a little bit more on that. Working with a dietitian to help support motility and give you more ideas, whether that's through diet or supplements. Gentle movement, so whether it's walking, other exercises, or yoga, can help with motility and digestion. And then the second point would be to reduce fermentation without over restricting from the diet. So when someone first has the diagnosis, this could be an area they might want to work on, is just to follow one of the diets or a version of the diet to reduce common maybe trigger foods that they have. And then the last but not least would be to prioritize bowel regularity, especially if they're having a lot of constipation, really making sure that they know they have a bunch of tools they can use to try to optimize their bowel movement so that their SIBO doesn't reoccur. And that can also include things like hydration, using fiber through diet or supplements, and then following their medical regimen that was prescribed by their doctor too.
Okay, that sounds good. Erin, what would you like to add to that?
Well, that was an incredible overview. So
Yes, it was
every
fantastic.
bit of that, Stephanie came very prepared and organized, which I love. Um, I guess the only thing that I would add is, and alongside what Stephanie said about like spacing meals, but really trying to optimize like the digestive process as much as possible. I do this for any patient, just because if we're looking at the gut needing to function well with motility or with proper digestion or whatever it may be, you know, focusing on relaxing with meals as much as possible, chewing really well. And then depending on the patient, I may also alter meal size. So for most patients, it is maybe 3 larger meals spaced really well to support motility, constipation patients. But if you come to me with diarrhea, and if it's SIBO driven, we know at least, okay, we can address the microbial overgrowth and like that diarrhea may improve. For some people, if you're having hypermotility and you lean towards frequency bowel movements, high urgency bowel movements, then we may alter some of your earlier meals in the day to be a bit smaller. So that spacing actually might be tailored a little bit more. So, you know, Stephanie mentioned there's lots of personalization in this, but making sure that we're supporting that digestive process as much as possible. And then even outside of diet, like improving toileting behaviors. And, you know, she mentioned supplements may fit in there in terms of helping support a daily bowel movement and bowel clearing, and adding in movement between meals, ginger tea after meals, always to make sure we're optimizing that digestive process.
Okay, that sounds really good. And how can diets, including low FODMAP or low fermentation eating, support gut health during those early maintenance, the early maintenance phase? Is just having that low fermentation and less burden on the body one of the ways to help prevent relapse?
Absolutely. I can speak to low FODMAP since that's what I use more. I love that Stephanie does low fermentation more. I've been a low FODMAP dietitian myself. But when we look at the low FODMAP diet, you know, one piece of it is the fermentation property of these foods and how much gas is being produced. And so if we're, you know, trying to support the treatment process and, okay, we've tried to kill off some of these microbes, we've supported motility. Ideally, we don't want to overfeed these highly gas producing microbes as they're continuing to die off. So during treatment and after. So there is that side of it. With the low FODMAP diet, I think something that's also interesting that I take into practice, even though we don't have research in the SIBO space yet with low FODMAP, or I don't think low fermentation either. I'm assuming we're going to get
Not
that
yet, but
research.
it's coming, I'm sure.
May know. But when we're thinking about some of the IBS research we have on a low FODMAP diet, there's some studies that show that those who show up with kind of a dysbiotic profile, which maybe we could assume that that could be some of our SIBO population overlapping with IBS. This study didn't necessarily test for SIBO, but they looked at like kind of post-infectious IBS cases, and these cases of IBS that had dysbiosis seen an increased intestinal permeability or that leakiness in the gut. When they followed a low FODMAP diet, that dysbiotic profile actually turned into kind of a normal, like healthy profile. And then, and again, not looking at SIBO, microbial overgrowth or these pathogens, more so general overview. And they also found less intestinal permeability. They saw stabilized mast cells, which are immune cells that can impact the gut environment as well, and like the reactions that people have to foods. And so if I'm using that in practice, thinking about a patient who's coming to me with, okay, they had dysbiosis fueled by possibly these pathogens and these specific microbes.
Sure.
They're going through a treatment process. Ideally, we want a less dysbiotic profile moving forward. There's some evidence to suggest that a low FODMAP diet may further support that process. So that's what I use in practice. And before I pass it over to low fermentation, I will say in actual practice, most people that I work with are already eating a pretty restricted diet.
Yeah, exactly.
So rarely in the maintenance phase of SIBO, I will say maybe 1 out of 10 people, we might start a low FODMAP diet fully. 9 out of 10 people are already restricting, usually FODMAPs plus plenty more. And so typically I actually use the low FODMAP diet to add foods. And so when we're thinking about incorporating foods that they had cut out whenever the disease state was very symptom causing, and now we've gone through treatment and now we're figuring out how to move forward, using lower FODMAP foods, maybe lower fermented foods, to start reintroducing some of these plant foods, these fibers into the diet, which the gut needs, gives us a bit of a pathway that feels safe and makes sense, right? That helps us kind of figure out, okay, this is what should happen. And ideally, these should be better tolerated, kind of keeping all those different pieces in mind until we have more research to show us exactly what's going on.
And an expanded diet's always a great idea, of course. All right, Stephanie, for the low fermentation eating, how do you approach it? What are the things that you want people to know about that?
Yeah, so the low fermentation diet is like an eating pattern that was developed by Dr. Pimentel and Dr. Rezai and the researchers here at Cedars-Sinai. And it mainly has two essential rules. So the first is to restrict some of the foods that contain high levels of carbohydrates that our bodies can't digest and that kind of get fermented by bacteria. And then the second one, which you've already heard us say, but spacing meals apart. Per low fermentation eating, it recommends 4 to 5 hours. But I really do work with patients on what's more realistic for them and their lifestyle. But it was essentially created before the low FODMAP diet. So it wasn't actually meant to be compared to the low FODMAP diet. The idea was that, they were getting a lot of patients coming in with SIBO. They were hyper focusing on food, having a lot of stress and anxiety around food. And they wanted to just give them a guide to say, like, here, you can follow this guide and you can go out and live your life and dine out at restaurants, so you don't have to be super restrictive. So in that sense, if you looked at the details of the low fermentation diet, that's why you might see that some foods are allowed, like garlic and onion. And for that example specifically, it was literally because they wouldn't be able to go out to eat if we told them to avoid garlic and onion. So small amounts are okay. And we just wanted them to be able to have a little bit more freedom, but have some guidance still. So with the low fermentation diet, they are still reducing their overall fermentation load if they follow this diet. So there are a few of the big fermentable foods that are recommended to reduce, such as artificial sweeteners. So those are going to be things like sucralose and Splenda, sugar alcohols, so anything ending in OL like sorbitol or xylitol, your legumes and pulses, cruciferous vegetables like Brussels sprouts, broccoli, some leafy greens, and then prebiotic fibers and some dairy. So essentially, it's just supposed to be a little less restrictive, keeping the big key players reduced in someone's diet who has SIBO. So those are the main points I touch on. It can be followed a little bit more long term, and patients do find it a little easier to follow, but I can definitely go into it more. I think some of the other questions will have me go into it more as well.
Well, one of the questions is, let's see, regarding meal spacing of 4 to 5 hours, I think it says, can I eat at least for 1 hour and then take a 4 to 5 spacing? Like how can they pulse that? Is there any, like, it's to get the migrating motor complexes, get that sweeping wave going. So that's why a lot of people I know take prokinetics at night and then they have a nice sleep and a nice fast. And then throughout the day, how do you help people that obviously it's going to be custom and blood sugars involved and all of that. Do you have any like cheats for that? Like, is black coffee okay? Like, what are some tips for the meal spacing?
Is the question asking if they can have anything during those 4 to 5 hour
I
periods, or
think
how do you do
so.
it?
I
Okay.
think let's do a little of both because I think
Okay.
it's a
Sure.
little cross-pollinated the question.
Sure.
Okay.
Yeah. Ideally, you're not really consuming anything else but water during the 4 to 5 hour break.
Okay.
But with that said, I even have patients who, a lot of times our SIBO patients have other comorbidities that need to be honored, whether like you said, blood sugar, or they are losing weight, but they're having a lot of symptoms. So this is a case where might start them off with a 3 hour spacing so they could still get 4 to maybe even 5 meals in that day. Slowly work them up to a 4 hour spacing, see how they feel. I personally rarely have someone get to 5 hours. I think it's pretty
Okay.
hard.
Okay.
Yeah. And then I also work with them so that they're not hungry during that time, right? So, optimizing meals, making sure, there's like protein, carb, fat in each meal, or having more complete snacks if they're throwing a snack into the day. So the idea is not that your current meals aren't optimized and you're just going long periods without eating while you're really hungry. I would actually, if that was the case for that patient, I'd prioritize optimizing their meals before spacing if they were having some difficulties.
That's good to know. It's already torturous enough to have SIBO,
Yeah.
right? Much less that you're now like really hungry all the time.
Mhm.
And sometimes I wonder about like, fasting in general and all that. I wonder if some of the benefits that everybody seemed to experience for several years when it was sort of very trendy, was that their migrating motor complexes were like actually working more effectively. And, it's kind of a little giggle, and I'm just glad it's helping people. That's the main thing. Okay. So I'm going to move on here. How can someone recognize? Actually, Erin, did you have any tips for the meal spacing?
Those were great tips. I use the
Those are
same.
great.
I will say that I also don't typically get to 5 hours. I try to
Okay.
aim for 3 to 4, but
Okay.
really just seeing where someone is starting. And again, looking at how their day flows, I find that usually if we get that overnight fast really strong, people tend to be moving their bodies in the morning. I tend to space morning to like early afternoon meals tighter just because that seems to flow better with like kind of more slowly easing into digestion, and then maybe having a bigger space in the afternoon and then that dinner. One tip that I usually will give is if you are going to have coffee or tea, like put it with the meal, and the same with dessert because people get kind of confused on that in the evening. I'm very pro dessert. I love dessert.
Right.
You should have fun things, right? Make sure that you're putting that with that meal in the evening because that can help a lot. And then some people do need to work on efficiency of eating because if you are eating over an hour of time or like sipping on a smoothie for an hour and a half,
Right.
like usually that's you're probably distracted, like that efficiency piece that I mentioned before might not be at play, so we may need to work on chewing. And if we're not doing a good job at that, maybe decreasing like the particle size of a meal. I don't know if you guys have talked about that with how the elemental diet is like the lowest potential particle
Right.
size. A salad versus a soup is a great example. A salad's going to
Right.
take you much longer to eat. A soup is going to take you a lot less time to eat if you're actually doing it. So that would be just another tip to make sure that, okay, what's actually going on with this meal? And then what else is happening? And, you know, the migrating motor complex, it's great, but it doesn't have to also control your life. If you're overly stressed that like you're not spacing it well and then you're panicking about that and then you're not eating well, like
Right.
you may throw your body off and your motility off if you're undernourished or you're fasted for too long. You know, you can kind of get into the weeds of that in a way that actually works against you. And so to doing your best, figuring out where you're starting. And then the big goal is just not eating and grazing all day long. And that flexibility can come a lot more too as you get past treatment and you see that symptom response and your gut's working well and, you know, some of those signals.
It's multifaceted for sure. Do you recommend a low FODMAP or low fermentation during diet during antibiotic treatment?
I can speak to my approach. I typically start wherever the patient is. Again, I would say 9 out of 10 of my patients are already restricted going into their treatment.
Right.
Most of them, as you guys have probably talked about, have suffered with symptoms for many years before they even got this answer, and those symptoms had progressed. And so usually food gets cut out. So I usually will say whatever we can get in terms of symptom response. I haven't seen anything to convince me yet that we need to add a lot of FODMAPs to the diet during treatment. And again, I missed earlier, so please tell me if there's something I'm missing. So I usually will just pair it to the patient of if we feel better already pulling back some of these highest trigger foods, whether that's just your highest FODMAP foods or just like beans maybe or just salads. I typically do that to get through treatment well. And then I typically stay pretty hands-on during treatment because some patients have symptoms, some don't. And then we might monitor diet and change a few things based on the symptoms they're experiencing to see if we can just ease some of that, the GI, the side of it. And patients who are doing great during treatment, I let them know in advance, like, if you feel amazing, eat the foods, like you're not going to ruin
Yeah.
it. And if you do, we probably didn't treat it properly anyways, right? So it's okay to eat those foods that you love, with some caveats of like alcohol and maybe ultra processed foods. But I'll let Stephanie share her approach.
Yeah. What are your thoughts, Stephanie?
Yeah, mine is similar. I don't really recommend any diet changes when they're going through antibiotic treatment. So I won't start someone on a low fermentation diet if they're going to start a course of antibiotics. My personal reason is I really want to see how those antibiotics are affecting their symptoms, and if we change too many interventions, we don't know which one was helping. The only other case, if they've been on a low FODMAP diet for a really long time, they're doing antibiotic treatment, I won't reintroduce or have them come off of it during that time either. I'll wait till they're done with antibiotics, then we can do a reintroduction process.
So the fact is that guys, if there are calories being introduced, the body will not do a migrating motor complex sweep, right? So is that accurate? Right.
Mhm.
So to say like if I want to have a piece of fruit to hold me over, that's going to have calories to it. So it's just you need to decide what windows are going to work for you. Maybe you're doing it every other day. Dr. Seebecker and I did a SIBO diets masterclass. The content was about, an hour and a half. And then it was 5 hours of Q&A. And literally, if I had $1 for every time we said, everybody's different, experiment with it, see how it works for you. And of course, there are the outliers that you've been talking about, like, garlic and onions and apples may just be like off limits for most people. I have a friend who has SIBO. She was able to do garlic, no problem. Give her an onion, she's going to like feel like she's deaf. So it's a little frustrating, I know, as a patient to keep hearing that, because you're like, oh, just someone take me away and like, just, make my food for me and make sure it's tasty and just like be in charge of me. But you cannot give your power away, ladies and gentlemen. You have to work within this very frustrating, very personal aspect of treatment, which is your food and your diet and the socialization. And that's really where I think nutritionists and registered dietitians are some of the most underrated supports when you do have SIBO, because they really have a lot of ideas and a lot of experience and can suggest so many great things. And just shout out to y'all, you're not utilized enough. So there you go. Okay. As we continue, I've a lot of opinions about that. All right. How can someone recognize early signs of a SIBO flare?
Great
I think
question.
I think that's going to be a quick answer, but go ahead.
Yeah.
Go ahead, Erin.
Yeah, I mean, I would say the symptoms, which is hard to say. Usually for my patients, I tend to look at motility changes first. We look at
Okay.
motility a lot, probably get annoyed at how much we're tracking motility, like how much volume of poop is coming out every day. It's like people get really skilled in knowing how well they're emptying and clearing. I will typically see a change in motility before I see like the pregnant belly bloat come back. Sometimes pain, I will say, will increase first. But obviously, if we're like back to, okay, I'm usually doing fine, and then all of a sudden I am extremely bloated, I'm very gassy, my bowels seem all over the place, like I would call that being in a flare. But Stephanie, I'm curious about you, because I know you work with even more within your clinic, how you address those flares.
Yeah, I think if it's like, especially if it's a reoccurrence, right? If it's early signs of SIBO, it's their first time, they might not know they have SIBO until they've had it for a really long time. But if it's a reoccurrence, patients usually, I kind of see similar symptoms come back that they have. So if they have a lot of bloating, they're going to see a recurrence of a lot of bloating. Whichever bowel movement predominance they have, that can return, but it can also alternate. So if they had methane and they got treated for methane with constipation, then they can actually have hydrogen on the next breath test,
Right.
and they might have a little more diarrhea. We also see like brain fog, fatigue, especially if they're starting to get deficiencies, and then an increase in food intolerances. If they're paying attention, some of them are like, oh, I can tolerate lactose, or used to be able to tolerate lactose, and now I don't anymore. And there's something that has switched.
Yeah, I will add, I think this is interesting, and I'm curious to hear Stephanie. I'm using my own time to talk to my colleagues. Something else that I think is important with that, because it's easy to say, like, you have symptoms come back, that means that there could be a SIBO relapse. It's also common, someone asks about, when do I trial new foods? Like, when do I start incorporating new things? Symptoms can still happen, even though SIBO may not be fully relapsed. So a lot of people have motility disorders or reasons for motility concerns, whether that's hypermobility or nerve damage, or I know you guys have probably talked about this all day, right? So there's a lot of different causes of symptoms, and having a day where you were trying new foods and you had a spark in bloating, that doesn't necessarily mean that it's a SIBO relapse and we need to retreat right away. Like, there is sometimes a look at, okay, what else is going on? What can we adjust? What can we understand about the symptoms you're having for a day or two? Menstrual cycle changes. There's so much that can contribute to symptoms. And also, I always say normal, hate the word normal, but people without GI conditions or problems have bad GI days. They have food that they eat that doesn't work for them. They have travel induced symptoms. They have stress induced symptoms, like their bowels get out of whack sometimes. And so we have to also understand that. I typically will think about, okay, this is maybe a SIBO relapse when symptoms have started, like they're getting kind of funky. We look at the picture, maybe we identify a few areas that we might make a few tweaks and adjustments. Maybe we expanded their diet, alcohol's been reintroduced, they're traveling, they're eating out more. Maybe we pull back a few of those things, find a baseline. If we can't get back to a baseline within a few weeks to maybe even a month in my more severe cases where there's a lot of complexity, that's when I start to suspect that there might be a need to maybe retest, relook at the SIBO picture. But Stephanie, I'm curious about what you do, because I know there's no perfect science to this. It's more of the art of it.
Yeah.
Yeah, absolutely. Yeah, I think Erin made a great point that I always tell patients when they're reintroducing a food, if they have mild symptoms, that could still be normal. If you haven't had a food in a long time, your body will have some nuances when it's adjusting to it. I agree. I think it's going to be like symptoms are kind of pretty persistent day in and day out, despite maybe some minor changes. But it's usually not a one-time thing. Like you maybe one day you had a super high fiber day, you're really bloated for 3 days and then everything's fine. Like I usually see that it's more persistent symptoms that are not going away with maybe some easier management tools.
I had some chia pudding the other day and thought I was going to die. But I didn't think like, oh, my SIBO's back because,
Yeah.
it was just like I shouldn't have had two servings of it. Okay, I followed oh, is chard considered a green leafy vegetable to avoid?
It is a leafy vegetable, but it is one in the way that like we cook it, or we usually cook it, right? It's usually like cooked chard. So it's one of those that I do tell patients, like if you're gonna have it, like add it to the end of your soup cooked.
Yeah.
Make sure you're modifying it in some way before you're getting it into your belly.
Versus like using it as a wrap. I've seen it as like a
Yeah,
wrap alternative. Okay.
yeah.
Um, and then this is just really repetitive. I follow Dr. Pimentel's low fermentation diet. I am better, great. But when can I try adding something back? Like, for instance, oats or grains. I am on antibiotics for the past 6 months, off and on.
Yeah, they're feeling better, and they kind of chose two foods that I think are generally well tolerated, like oats and grains for a lot of our patients. So those are actually some of the foods I usually have patients reintroduce. You could still do small amounts if you want to at a time and slowly increase, and then you can like quinoa is a grain that tends to be pretty well tolerated, but it's they still have fiber. So depending on your current fiber intake, you might just want to take it slowly as you're increasing. But yeah, as long as you can kind of tell a difference if you in your symptoms, if you were to eat something, obviously we said you want to have it multiple times and not just take the first mild symptom saying that you can't tolerate it, but it would be a good time to reintroduce some foods.
Okay. What strategies are most effective for managing a flare when it occurs? We've kind of touched on that, but do you go, broth? Do you like just what do you do? What do you do for your peeps when that happens?
I keep my clients eating as much as possible. Again, unless some severe cases or patients also know themselves. And so if a patient knows that maybe an elemental protocol for a couple of days or doing a broth for a bit and maybe extending a sort of semi-fasted period works for them, great. I typically don't recommend that. I like to keep the gut fed to hopefully get out of that flare as much as possible and like keep motility moving. One thing I will do is I will often pull back into the lower FODMAP, like safer foods, and that is very personalized. Again, based on the person, what they've experienced, what we've found out, but typically, again, lower FODMAP, lower fermented food. And then I do decrease particle size. And so, like I mentioned before, instead of going for if we've progressed to things like salads and bigger meals and even cooked foods, but let's say we're doing like a whole baked potato or we're doing a lot of cooked greens or like even broccoli florets, something like that,
Mm.
that's going to take up a lot more space. During a flare, I may recommend that we chop things up even more. Maybe we blend them. Soups tend to be a great approach that I will use.
Right.
I say no alcohol. I know alcohol is a tricky one, but that is obviously our biggest gut irritant. And a lot of people in the SIBO world cut it out and they're fine with that, which is probably the best move. But if someone has wanted to bring that back or excess caffeine, then I may try to pull some of those things back. And the biggest thing that I recommend is, okay, let's look at the full picture. Are you sleeping well? Are you
Mhm.
are you panicking? Do we need to calm the body? Not that stress caused it all, but do we need to calm the body down, take a period of rest? Are you overstretched, and can we somehow take some things off your plate? Like give yourself a period to kind of rest, just like you would do during a SIBO treatment. Are you moving your body gently, or are you
Mhm.
holding everything intense because of that flare? Can we find ways to incorporate a little movement? So it very much is personalized, but trying to get back again to that baseline as much as possible.
Did you want to add anything to that, Stephanie?
Yeah, I agree with everything Erin said, especially reducing known trigger foods. Like that might be the time where you pull back. And this is also a great time where supplements can be used. So maybe this is, I think I saw somewhere in the question about Fodzyme. I love Fodzyme. It's been very helpful for a lot of my patients, but especially if it's a flare that has occurred and it's like the 10th flare they've had, and they're tired of having to like change things in their diet, but they know, oh, Fodzyme works well, that might be the time to start using it a little bit more often. This is where you can start with fiber supplements if your bowels have changed, or certain like peppermint supplements to help with bloating if that's a symptom. But I really always look when I'm working with patients as dietitians, you know, sometimes we have to talk about things black and white, but individually when we're working with patients, I don't usually say, oh, start the low fermentation diet. I'm like, all right, I know you pretty well. Seems like you might be eating some of these trigger foods, or you're really, really stressed right now. Let's not even talk about diet. Let's talk about some non-diet therapies. Maybe it's like a gut-directed hypnotherapy app. Maybe like Erin said, focusing on sleep if you're not getting any sleep. So I think there's definitely a lot of tools, and I think it's really like what the patient needs the most at that time for that flare.
And in terms of like malabsorption, SIBO is a malabsorption condition. So that smaller particle size, digestive enzymes like Fodzyme or what FODMate, there are some really powerful ones out there that really can help. Latrina, I see your question about that. And just really focusing on getting that overgrowth down so that those bad players aren't stealing your nutrition and you can get the microbiome back online. And hunger noise, which you hear a lot in the GLP world, and how GLP-1s have helped with hunger noise. And I know genetically some people are more predisposed to hunger noise. Food noise is the word with phraseology, but I think everyone knows what I meant. Do you and then you want me to not eat for 3 to 5 hours? It really, do you ever do like an essential oil? I have someone asking here about what's your experience with electrolytes containing no calories but stevia or monk fruit, or both, during the 3 to 4 hour time window between meals. Erin, go for it.
Yeah.
I'm actually not sure. Have they looked at the impact of stevia and non-caloric sweeteners on migrating motor complex yet?
I think Dr. Pimentel is not a fan of stevia on the migrating motor for the migrating motor complex. So
that's what I believe. I think that
yeah.
the general rule, I guess, with limited data, like we're working off what we got,
Yeah.
I believe that it is not using non-caloric sweeteners. I probably honestly wouldn't do electrolyte. Well, I guess depending on the patient, like electrolytes can sometimes support motility. Sometimes they may make you poop more. So you have to be kind of careful with like timing of electrolytes. I would not do that. I don't know, Stephanie, do you have any opinion on the non-caloric sweeteners during fasted?
Yeah, I agree with Siobhan that we don't really prefer stevia, monk fruit either from a low fermentation diet, but I have found it is almost impossible to find a product that does not have monk fruit if it does not have regular cane sugar. It's just what is being used in almost everything right now. But yeah, I think if I was working with the people who have been asking this question is I probably wouldn't have you probably space your meals if you're trying to find something to eat in between these times. So maybe there are so many other interventions we could use for you that wouldn't make you feel like you're giving up so much for these 4 hours or 3 hours. But for stevia monk fruit, I would not use those if someone has SIBO to the best of their ability.
What about like lemon water?
I typically would. I think
is there a calorie in there that would impact the migrating motor complex, do you think?
Probably. I know people are kind of iffy on even like black coffees. You get like calories per cup. I think that how big of a difference does it make if you're doing that once? And again, I think that's looking at the day in a bigger picture, because if it is like, oh, well, my morning, I'm trying to figure this out. It's like, well, you just had that overnight fast. Like every single meal doesn't have to be spaced up perfectly to get the benefit. And again, more severe cases, you may approach that differently, but I would not, if you're really trying to test it. But I also, like Stephanie said, I would not start, if you're a grazer, like you're snacking, eating, you're drinking flavored liquids all day, like that's your approach currently. I would not start you on a 4-hour fast between meals.
So let's move off of that. Right. Yeah.
Yeah. I would probably say, okay, let's space like dinner, like let's tighten up your dinner and after dinner snacks, and then help maybe before bed. And then I would probably go to, okay, before dinner, what's going on? Are you exercising? What's happening there? And then I may work to lunch, like kind of working one meal at a time and only spacing a little bit more than where you currently are, so that you can test that, like, okay, do I need to add more fat to this meal? Do I need to add more protein? Do I need to add some fiber? Because if you've stripped your fiber, your meals are going to be a little less satisfying, and we might need to bump fiber or protein and fat for a little bit while we're building up fiber, but we also may need to incorporate some with meals. So I think it's a lot more creative than that. And so if you are struggling, I would say if you have a dietitian, make sure you're telling them that, and asking like, hey, I need to figure this out. Like I'm not fitting into this perfectly. Like I need to kind of figure out these trouble points. If you don't, find one if you can. I know we're not all available, but also trying to, and this might help with like finding a friend or finding someone that you trust, of like having an open conversation to where it's like, okay, here's the plan. I'm supposed to space my meals. Here's my problem. Think about it as if it's not you. How would you troubleshoot that, right? Because some of it is a little logical. We just get our logic taken out a lot when we're also dealing with symptoms and we're trying to do our best and we're in the mix of it. So that can help if you're trying to guide yourself of like, okay, I'm struggling with this. What can I do? And again, one meal at a time, just tightening up so that you can really test how you feel. And then if you have a little bit of flexibility at a certain point of the day, you're still likely better off than where you started with your other meals of the day being spaced well.
You
The
sound
same
like
is
you're
true of like
doing a chat
fiber
GPT
intake.
prompt, Erin. Like, right, which is
Yeah,
great. I've done that
that's
before.
great. I'm pro that. I
Yeah,
think it's,
take the food
yeah.
list that you're supposed to be dealing with, and you're like, okay, I don't like peas, I don't like, cabbage or whatever it is, and say, I'm a picky eater, whatever, and use ChatGPT, and then use it in conjunction with human intelligence, and work with your provider, and it can come up with some really wonderful meal plans, and the borderline to not cross is hypervigilance, right? Because that's when it gets quite, I don't want to say dangerous, but it can be scary. And you can be like, oh my gosh, like, I just don't think this is sustainable. And if it does feel sustainable, it might be a problem because this hypervigilance is not serving me well. And one of the questions that we had pre planned to ask was about the mental, psychological, and emotional state of being on a somewhat, I want to say, restricted diet with flexibility. And it's easy to get a lot of decision fatigue around all of this, which is why we have so many questions going, what about this, what about this, what about this, what about this? And I get it, believe me. I remember standing in my kitchen back in 2000, I don't know, 15, going, oh, an apple a day keeps the doctor away, I'm hungry, I'm gonna go have an apple. And I was just like, whoa. So it's a lot of decisions. You need the science, but also you need to relax into it at the same time. What's your best mental health advice, knowing you're not a mental health professional, but you are a highly skilled professional in this field? What's some advice that you give to your clients? Either one of you, go for it.
Yeah, so I am also someone who has long-term GI issues and I have SIBO myself, so I am in your shoes. I get the toll that it takes when you're trying to just function in life. And my biggest tip is to normalize your emotions. I think when we have GI issues, it doesn't feel good if we're negative about it or when we're angry or sad or all the negative emotions that we have. And it feels better when we're in our positive moods and positive states. But I just want to normalize that it's okay to feel all these different types of ways about your condition, especially as women, our hormones change on a daily basis, and that might affect how we are perceiving or how we're feeling and doing that. So I think the more we can kind of tune into how we're feeling and honoring what we need, and really tuning into that can be so helpful. And that I do want to touch on, one part of this too is that right now we don't have almost any research outside of elemental diet on diet and SIBO. So if this has caused you to like really hyper focus or, try to go in the weeds of diet and what to do, I've had patients that follow low FODMAP or low fermentation diet to a T and their SIBO comes back. Patients who don't follow anything and their SIBO comes back, and vice versa, where they could do whatever they want, the SIBO doesn't come back. So there's no guarantee.
Right.
And I say that more to just give you some relief if you're having a week, if you're a parent with children, if you're traveling, if there's something going on in your life that you can't follow what you've been following for the past few months, that's okay. And sometimes we need that. And there's always things we can do to get back on track. But and the other piece that maybe Erin, I don't know what you'll touch on more too, but those non-diet therapies are so helpful. I'm also a yoga teacher, so really like love diaphragmatic breathing, abdominal massage, movement, gut-directed hypnotherapy. There's like all of these tools in our toolbox that we can pull out and use based on what we need and how we're feeling in that moment.
Absolutely. Those are such good tips. And I use the same. One thing I like to talk to my patients about, again, a chronic gut person as well, like chronic IBS-C with some hypermobility stuff. So for 20 plus years. So I think I get it. And something that I think helps, and I think something that is important to talk about in this space often, is that we're not necessarily focused with these diet and lifestyle therapies on a cure, right?
Mhm.
We're focused on symptom relief, yes, like the treatment part of it, but the goal is chronic management, chronic support for our bodies. And I always say that, with IBS, and some people, I always joke, like, you're probably want to punch me in the face for saying this, but sometimes I'm thankful that I have the conditions I have, because it's really forced me to really take care of my body at an earlier age. And I don't know what's going to happen. I can't control everything. But the way that I look at it is, what am I trying to put into place that I can sustain long term, that's going to continue to serve my body well long term? I will grieve what I have to lose with that. I will grieve some of the choices I have to make, but I'm also going to be proactive in figuring out how to make things work well for me. Now, if you're starting with a lot of symptoms right now, not a lot of answers, you're going through the treatment of it all, right? And things are not where you want them to be yet. You're not able to eat a lot of foods. Like, it's hard to look at that and look at what's next and what's ahead. But if you're looking ahead thinking, I just need something that's going to fix me tomorrow, you might be set up for a lot of frustration, especially from a diet perspective, or like you mentioned, like gut directed hypnotherapy, just doing a gut directed hypnotherapy program and then filling your life with a lot of stress and never sleeping and never moving your body and forgetting how to breathe and disconnecting from your life. Like, it's probably not going to be an option, right? Things are going to get worse. You're not going to feel good. And the same is true of diet. You can't go from, okay, I'm going to do a low FODMAP diet, and then I'm going to eat a lot of highly processed foods. I'm going to drink alcohol every night. And then I'm going to, just go into that approach. Or I'm going to go to a raw vegan diet and eat all the fiber in the world. Like, it may not work. And so we have to think about, okay, how am I moving forward in a way that's going to be sustainable? And then how do I continue checking in with myself to create that flexibility, to adjust it a little bit, but looking at it as more chronic management? And there's a lot of freedom in that, because it does take away that all or nothingness of it all. And it also takes away some of those expectations of like what's on the other side of it, and gives you that freedom of, like, if you love pizza and you've tried it again and again, and just the pizza you love isn't working, okay, how do we modify this? How do we make another version of this? Do we use Fondime? Do we make our own and figure out how to make an amazing pizza? Do we search out a pizza that is gluten-free if that's what you need? Like, what is it that we need to do to make this work, versus I just can't have pizza anymore?
Right.
Just kind of that mind shift.
Right. Okay. Before we wrap up, how can people work with each of you? Do you have to be in California, Stephanie, to work with you, or what's up? We'll start with Stephanie. How can people work with you?
Yes, so I had 12 state licensures, but they're slowly all going away now that I'm at Cedars. So I apologize, I don't remember the states I'm still licensed in off the top of my head, but definitely California. I can see any patients actually from California at Cedars. If they're out of state, they do have to come in person to be able to see me, but you don't have to be working with the doctor here at Cedars-Sinai to be able to work with me.
Okay, great. And Erin, how about you?
Amazing. I have getovate.com as my website. I do take a limited amount of one-to-one clients. I've pulled back some of that, but I do have an online program. It's a membership and it's geared towards IBS, but there is a lot of, there's a forum in there and like live Q&A calls each month. And so we have some stuff on SIBO and some of these specifics, but a lot of those strategies I talked about, there's courses on that, but also some Q&A type of care from me there currently. And then as I have one-to-one client availability, I do see some people. But I also have a great network of dietitians that work in different clinics as well as in private practice. And so if you are searching for a dietitian, always feel free to reach out, and I can always do my best to try to put you in the right direction.
And just a few more questions. I have burning mouth syndrome. Hey, Sandra, sugarless gum is recommended, but it has xylitol in it. I chew 2 pieces a day. Each piece contains 1 milligram. Teeny tiny. Do you think this is hurting my SIBO?
Depends. I mean, sometimes that can cause some gas and some symptoms, but if you are feeling good, and I guess this depends also where you are in your process, but if you are past the treatment process and what is you're doing is working and symptoms are pretty well controlled and you're still chewing your gum and you're not having a lot of excess gas, I don't see a problem with it. I'd probably put it close to meals just in case. Xylitol actually can help a lot with teeth health. And so that's one of those like, how do we use this if it may cause more symptoms? But if you are having a lot of gas and bloating throughout the day and you're not sure why and you're doing that, that might be something I would look at of a trial, removing it for a little bit, see what happens, then reintroduce it maybe with one piece per day, see how that goes, and then move on from there. But if you're not really having a lot of symptoms, I wouldn't take it away just because.
So
I
that what
completely agree with that. Nothing
right.
to add.
So what they just described was the thought process for everything. Like
Mhm.
experiment, see how you're doing. I mean, it takes a lot of energy. It definitely takes, it's like a part-time job. So there are a lot of emotional implications and, you know, like having a lot of grace for yourself, a lot of patience. That's where the resilience comes in, that you have to just like continue on when you want to give up and then just like have that whole pizza anyway. And that may happen. And it doesn't mean that you're going to relapse into a fiery hell. So just like hang in there, hang in there.
Yeah. One thing to add to that, I think that because that reminded me of something. The biggest piece I think that's so helpful for patients is knowing what triggers their symptoms, right? So to Erin's point,
Mhm.
if this person didn't know she was having bloating and didn't know why, then we could find out if it is the gum. And just say if it was, then you can always weigh in the mind, are the mouth symptoms worse than maybe some bloating from the gum? So that's the thing we're always trying to get to. I always tell my patients if I have them ever cut out something for a certain period of time, that doesn't mean that's how it has to be forever. They always have the choice if they're okay with some of the symptoms they might get from that food when they bring it back in. It's just kind of giving them that power so they can better plan when they have like certain engagements or things like that.
Great. Okay. What other things? Let's see here. Hang on. Erin, your website is gutivate.com. There you
Correct.
go. Okay.
G-U-T-I-V-A-T. That's confusing.
Okay.
Gut debate.
Spell it again.
G-U-T-I-V-A-T-E.
Okay. Great. Pure monk fruit, is that still okay? Or is it still a problem, even with zero alcohol?
I find people tolerate monk fruit pretty well. I
Yeah.
know Stephanie had mentioned maybe it's not necessarily allowed isn't the right word, but recommended, I
Right.
guess, on the low
Mhm.
fermentation. I would say it just depends. Usually, what I'm looking at those, if you are, and we didn't talk about like ultra processed foods and like a Mediterranean diet, healthy diet. That's obviously our goal eventually is to get to as well balanced of a diet as we can within each person's needs. But if you're filling your diet with artificial sweeteners, not that I hate them or that there's anything wrong with them, but if that fills your entire day, and so you're just grasping at, okay, well, I can't have stevia anymore. I need to, like,
Mhm.
we may need to look at some of like the flavor palette of what we're eating and like kind of look at things as a whole there too. Like, not to demonize those things or that you can't have anything from a package and that's just not reasonable, but just something to think about with that.
The bottom line is you have these tools, right? So can you imagine people how many years ago did not have this wisdom and this tools and they were probably like, what is wrong with me? And I just feel so terrible for people who did not have this science to work with. So so Stephanie, you're at the goodlfe.com, right? Is that how people can find you, or do they find you through Cedar Sinai? How could people who in California who want to work with you find you?
They can find me at the Cedar Sinai. They could type in GI Motility Center and there's a
Okay.
number to call and they can make an appointment there.
Okay, great. All righty. One of the last questions, we just have a few minutes left. I read that sourdough bread is okay, but know that whole wheat bread is a no. A lot of sourdoughs have whole wheat listed in ingredients, for example, organic wheat flour, water, organic stone milled whole wheat flour, sourdough culture salt. Would this type of sourdough be okay for SIBO?
Yeah, I don't know from a low fermentation perspective, but from a FODMAP perspective, the
Mhm.
fermentation process does break down the fructan, the FODMAP in wheat. So most people do tolerate sourdough better. One thing you look for on that label is that culture that shows that it has been slowly fermented. If something has been like more quickly, so the rise of sourdough trends, you do see
Yeah.
some that have like yeast added and may not be slowly fermented, so that effect may be less. And then from a SIBO perspective, looking at fermented foods, I know some people don't love high increase of fermented foods. Sourdough is a little bit unique in that you aren't getting live microbes from sourdough. So it's not like kefir or yogurt or kimchi or those foods where you're getting the live microbes. With sourdough, those microbes are cooked out so that they do die, but you're getting the effect from those microbes, meaning that decrease of the fructan or the FODMAP, because microbes feed on sugars. So they're feeding on those FODMAPs. It does still have gluten, so that's something to weed out as well. But if you have non-celiac disease and you're trying to implement some other foods, sourdough is great. Also, a lot of slow fermented sourdough breads that you find are going to be lower fiber in a lot of cases. So sometimes that can be a nice option if like a whole grain fiber rich bread is not a great option for you based on where you're at and the gas production from that. Sourdough can be a fantastic option to kind of test the grain a little bit without so much fiber added. If you want to add fiber, just sprinkle some flaxseed on top, which depending on where you're at may be an option, but that's how I boost the fiber of a sourdough.
Okay, good one. What if you have pots and need electrolytes?
Yeah, I work with a lot of pots. I typically will do a homemade solution. So you can do salt, like a half teaspoon, depending on your recommendation. So we recommend from 3 to 10 grams of salt per day. So it depends on where you're at with that recommendation. But usually the salt solution in water is going to be about half teaspoon of salt in a liter of water. And you do drink it throughout the day. Now, from a meal spacing, again, this is that complexity of overlapping conditions. Usually we will add some sort of flavoring to that, but you can also heavily dilute it more to where you don't have to add any other sweetener to that or lime or lemon to that. You could also, instead of sipping throughout the day, like add, okay, 8 ounces with breakfast, 8 ounces with lunch, 8 ounces with dinner, but you still want to spread out the salt throughout the day. And then don't forget that you can add salt to food. So making sure that you're adding it to your meals. So anywhere you can sprinkle, add a little extra salt or sodium, like salt rich foods as well, that you can incorporate, like broths are great for that because they have a lot of salt and sodium in them.
Stephanie?
Yeah, those are great tips. I'm even learning from Erin today. I know she does works with a lot of pots, like she said. Yeah, I think those are great tips. And I think if they wanted a little bit more control over the ingredients, like liquid IV is one that doesn't have an artificial sweetener.
Oh, good.
And then if you make your own recipe, you can also make it with straight cane sugar. And I think even if they were just having that, but they were still able to space their meals and they're following so many other recommendations, you have to have a significant amount of salt with pots, obviously. And so that might outweigh maybe like not doing the salt because you're afraid of affecting the migrating motor complex. I think when it comes to diet and exactly which specific things trigger it, I do think we still don't have all those details, but I would prefer, I think it's like with the liquid, I think it would be fine.
Last question. LMNT, is that okay? I think somebody said, is it okay? LMNT.
It has pretty high sodium, so you're looking at
Yeah.
1,000 milligrams or a full gram of sodium. So it is a great rescue option for people with pretty severe like dysautonomia or POTS. It can be really good. In terms of the packets that are flavored, I do believe that they still use stevia.
Mm-hmm.
I need to double, I always have to triple check because I feel like
Yeah.
companies have changed that so much. They do have a non-flavored option. So if you are concerned, I find people tolerate the flavored ones pretty well. I utilize them in my practice sometimes because they do tend to be pretty well tolerated. And again, they are that pretty high amount of sodium. So for like a rescue situation, they're nice. But if you do not want any flavorings added, they do make a non-flavored option. They also have a recipe for their actual formula on their website you can mimic and kind of replace.
Oh, that's nice.
Which is basically what I said. So, but they will have the other electrolytes like potassium. I think they have magnesium as well. So they'll round out the electrolytes beyond just salt.
Okay, last question. Because we are out of time, everybody. We have been going since like a long time. Okay, hold on. Of course, now you guys are flooding me with questions. Okay, how to reduce hydrogen sulfide gas from the colon with diet? That's a biggie.
Yeah, so there were about 3 studies, I believe, with low FODMAP diet and its effect on the gases. And actually, no, I think it was actually hydrogen. I'm not sure if it was hydrogen sulfide now that I'm thinking of it, but it did have the diet tended to have the most impact, like lower fermenting on hydrogen. Can't remember if it's a hydrogen sulfide, and then methane had less of an impact with dietary changes. But Erin, I don't know if you know more, if you can correct me.
We have 1 minute.
I also agree. I don't think that there's a hydrogen sulfide diet that
Not yet.
study that we have yet.
Yeah, not yet.
I
Let's put
think
some.
just increasing fiber, actually, now that I'm thinking of another study,
Mm.
increasing fiber had the most impact on sulfide versus reducing sulfur in the diet or protein in the diet.
Oh, interesting. Okay. Let's put some love into the Q&A box and some hearts for these two genius, incredible RDNs. Thank you very much, Stephanie. Thank you, Aaron. We do have some giveaways to get to, but that was great. Really, really helpful.
Thanks so
So
much.
there is a lot of hope, everybody. And get with one of these fabulous people to support you. And their cookbooks also, if you're bored, because I see some people say, I'm sick of this food. Like there's some great cookbooks out there and great recipes online too. So thank you very much, ladies.
Bye.
Thank you.
Bye
Thanks,
bye.
everyone.
Thank you. Take care. What a great SIBO Awareness Day 2026. Thank you so much for your participation and your attention. And thanks to the organizers for inviting me to be the host today. I am truly honored. I do have 3 giveaways to wrap today up with. One is the Good LFE book, which is the low fermentation diet approach. And that is that is going to be the next giveaway. So you do have to fill out the poll that they're going to put up for you so you can enter in. Do you want to win both books from Good Life? It's 2 books. That's great. And we're going to let you fill that out for a few minutes. And then we're really finishing with a bang because the next 2 are also really big and great. And we'll just put a minute here on the clock. We're going to go a couple of minutes, like literally 2 minutes past 5 p.m. Eastern time, so we get a chance. Hannah, can you just restate that for me in chat? It's just, I don't know what you mean, babe, about the one of the giveaways. Okay. So just restate that for me in a different way. Okay. I see. So it's not a giveaway, it's just a discount code. Okay. All right. Tell me when you're ready for the next one from Modify Health. Okay. Got it. Okay. Can you give me the code so I can tell everybody about that? And Modify Health. Modify Health is a food service that has delicious meals. I've used them in the past. 10 meals is the giveaway, which is a lot. That's great. They have great smoothies. Here's Modified Health. You can check them out online and see they have low FODMAP food delivery service. Basically, it's beautiful. I've bought their stuff before. It was very tasty, and also you can see what they're doing to get some ideas for your own kitchen as well. So 10 customized meals from Modify Health. That is a big value. That's our well, we've had a lot of good values today, but that certainly is one of them. And then after that, I'm going to give you a coupon code for Reflux Raft. So be sure to, thanks for being here. I mean, this was a long day. It was super special, 4 hours in for the SIBO Awareness Day. Lots of people pulling things together here to make it happen, including all of the great sponsors and speakers. And I hope that today you're not overwhelmed. Instead, you're inspired and will take right action. And doing things in the right order, I think, is really important. When we circle back to 1 p.m. Eastern Time and Dr. Allison Siebecker showing the protocol and the 9-step algorithm, shows that it is a cycle, it is repeatable depending on where you are, and that there are things to be done in proper order. Okay. Modify Health, that's 10 customized meals and yum, yum, delivered right to your place within the US, within the continental US, I bet. If for some reason your questions were not answered today live, we did our best. Be sure to check out SIBOawareness.org and make sure you're subscribed to their emails. They're taking all the unanswered questions and will answer as many as possible in their email newsletter. That's fantastic. They're also constantly adding new research, ongoing resources, and FAQs. So it's a great newsletter to be on so you can stay up to date with the latest and greatest research. And then the last thing that I wanted to mention was 25% off. That's a nice juicy coupon of Reflux Raft products with code SIBO25, as in the percentage off, for an alginate-based reflux support designed to help reduce heartburn and reflux symptoms, available to all participants. If they ship internationally, of course. So what that does is it creates literally like a raft in your body, in the esophagus, to help with the lower esophageal sphincter to reduce the acid from coming up. It's a very innovative way to address reflux. It's big in Europe, and I'm glad to see that we have some access here in the United States. So that is Reflux Raft, and the code is SIBO25. You'll be receiving an email with a bunch of great discounts from all of the partners discussed today and the recordings from today. So be sure to check out your email later on and forward it to a friend who you feel could benefit from them, and invite them to sign up for the newsletters as well so that they can get the information in their inbox. I'm Siobhan Sarna. Thank you so much for being with us today. What an honor and pleasure, and spread the word. Get SIBO awareness out there, educate your friends, your family, your practitioners, because in some cases, I know some of you are going to know more than they do, but that's just because they didn't learn about it in school. Their intention, I'm sure, was to heal people, and hopefully they'll be very open to what you are suggesting and sharing with them. And that is the way we change the world, by one tummy at a time, as they say. So thank you very much to the team. Oh, thank you so much. Sadie, you want to do a big final farewell? Come here, Sadie girl. Oh, yeah, baby. Big finale from Sadie. Bye, everybody. Thank you. Thanks, everyone. Thanks, guys.